So we have already covered imaging in stroke, general management, thrombolysis. So what we are left remaining is extended window lysis, contraindication lysis, and EVD. So welcome students, and we have our all two faculties or my own friends there. We will continue discussion. So actually, this session has more contradictory areas, like which are practically difficult, even for entrance purpose it is difficult. So there are a lot of ambiguities, lot of confusions. So we will try to sort out only those is required. I'm not going to cover the entire thing because a stroke, if you see the new guidelines, it will be some how many pages? I think some 200 pages. It's a very huge book. I have not count the pages. Partha, you were telling us some.
Yeah,
Yeah,
it
now
was, I think, more than 120 or 130 pages, I think.
yeah, there are now participants are increasing. They are actually 40. We'll wait for one minute. Yeah. So we will do one thing. We'll just do whatever we had covered. We'll just brush it. So for students, what we covered was basically one is imaging in stroke. So basically, imaging in stroke again, you can do any image, whichever possible, either CT or MRI, if feasible within 25 minutes. If it's not feasible, you go with CT and preferably with angio. That is what the same in more guidelines also. There is not much difference. But if you suspect LVO, angiographic should be included, which can be done along with or later. The major change is one is the third point, that is a pediatric MRI is always preferred. Second is if pediatric MRI cannot be done, then you can do a CT angio. Suppose you are unable to do that because many times pediatric patient difficult to go for an MRI, they cannot be able to difficult to lie down sedate. That is again a practical scenario we are going to face when we start managing. Luckily, I am not a pediatric neurologist. So in wake up stroke, again the whole guidelines remains the same. MRI diffusion player mismatch less than 4.5. So major difference in wake up stroke is the second part. That is a perfusion image is suggested for those more than 4.5 hours, which we are going to discuss in external window. Then introduction of posterior circulation aspects, which was there previously, now came in the guidelines. And for urgent vascular imaging, creatinine should be delayed. This is what is imaging in stroke. Basically, it is the almost same only. Difference is one is pediatric stroke, MRI is preferred. Second is the time for taking the image is 25 minutes right now. And third is wake up stroke, more than 4.5 hours to 9 hours, you can do a perfusion image. Then posterior circulation aspects is there. These are 3 or 4 major changes which happened. Then in EVT, endovascular therapy, again, it's almost same only. Up to 6 to 24 hours, you do diffusion pair mismatch. MR perfusion can be done. Just like what we were previously having diffuse and dawn criteria. You can remember like diffuse, which use diffusion or perfusion. So diffuse study was basically based on perfusion images, while dawn was based on clinico-radiological mismatch. Then another new thing which we stated the third point, that is only new thing. For entrance point, you should remember the third point. That is LVO is based on a raise 4 score. If it is raise score more than 4, and you can directly take to angiographic salute. Suppose you don't have time. Patient came directly. You are planning for LVO. You think that is LVO based on raise 4 or even based on your NHS or clinically. You can directly shift to angiographic suite and do a CT in the angiogram, I mean in the DSS suite, and lies it there, then directly take for DSS. You can delay, I mean, you can reduce a lot of time because practically we see it will take some time to like lot of time actually. In fact, in shifting from ER, arranging anesthetics, going to angiogram room. So it will take some time. So at least 30 minutes to 40 minutes you can say. So that is the new thing. So in EVT, the major change is the DTAS. So for entrance point of view, you should remember the DTAS. And this general measures, again, we discussed the oxygen supplementation, post-lysis. The major changes, oxygen supplementation is suggested even with normal SpO2 for those with LVO, that is large vessel occlusion, planning to take for EVT, which will improve the outcome. Second is lysis as well as for intervention, BP cutoff is 140 to 180 practically. Non-intervention, again, it is same, but they are telling reinitiating or reinitiating non-interventional patients, benefits is uncertain, but still we can reinitiate in some situations. Some scenarios we don't reinitiate, some scenarios depends upon your clinical skill, but this is what is the guidelines still. So that is the changes in general measures. Then lysis, the major changes, NHS and aspects doesn't matter. What matters is the deficit and the window. So if it is disabling stroke within window, lies the patient. Only you have to check the contraindications. Definition of disabling stroke is much more clear now. Remember the mnemonic BATHE. You should assess ambulation, you should assess salivation, and ability to solve before going for lysis. And tentative-based, the evidence is much better. And previous guidelines, the dose was 0.4 and some cases still 0.25. There is a confusion. Right now it is 0.25 milligram per kg. But again, Indian guidelines or Indian approval is for 0.2 milligram per kg. That both are there in India. Other thrombolytics like reteplase and proeurokinase has been suggested. Another major change is lysis pediatric thrombolysis. So basically, pediatric thrombolysis and pediatric thrombectomies are there, but cutoff for the age, you remember, 28 days. Again, the experience of the interventions with the pediatric patient, the mimics which can come in pediatrics, which all things we have discussed. So that were what we have discussed till now. Now we are going to start from extended window thrombolysis. I think we have some 66% right now. So that was what we have done is a brush up to what we have discussed in last session. Now we are going to extend window lysis. So Chandu and Partha, we were going for some CMEs. We are hearing that new guidelines is up to come, and that will break even, and that will make you do lysis even after 4.5 hours, right? So. Actually, that is a difficult scenario for us because actually we see a lot of bleed. I mean, when windows are delayed. What is your experience, Partha?
The main problem is that unlike the Western scenario, I feel that when in that tricky situation, you are in a gray area whether you need to lyse it or not. Maybe if when you give a full dose, the chance of bleed is more. Sometimes directly going for a thrombectomy is more feasible in those kind of scenarios if there is a large vessel occlusion.
Yeah. Again, there was a study which was done in timeless trial on tentative place in late window, 4.5 hours, 24 hours. But that trial was a failure. So that is one thing. Second thing is why we have more bleed is I think like we have already discussed. Our patients have small vessel burden. And our patients, most of the patients, the collaterals are actually much lesser when compared to European or US patient. Basically because our lifestyle plus our genetics maybe. What do you think,
Yes.
Chandu?
Yeah, the Western literatures, no, these are all favoring Western literatures for our Indian setup, our ethnicity. I think more of small vessel strokes are more common, and risk of bleeding also is little higher. So we should be a little cautious enough for using lysis, and especially in extended window also. No? The imaging, the time period, wake up stroke, the imaging which helps you to guide whether lysis has to be done or not. So these things has to be taken into consideration. I feel so. The risk of bleeding is another major problem that we are facing now in with most of the patients in the Indian setup, as compared with the Western studies. What they tell us that you go directly with the lysis. Whatever
Another thing is that the availability of cryoprecipitate and all those things that you immediately give once the patient bleed. It may not be available immediately in all the setups in India.
Correct.
There,
we have to be a little cautious enough.
Setups it is not available. It's not that easily available in India.
that maybe they are recommending the thrombolysis in all these scenarios because they have that backup of all the medications to stop the bleed once they get it.
Yeah, correct. That is also one thing. But again, for students, let us come back to the extended lysis. You see, when you look at the new guidelines, there is something known as extended lysis, but actually, practically, there is no extended window practically going to come in this guidelines also. So it's basically the extended window lysis. It was basically designed initially in 2019 for diffusion flare mismatch for a wake up trial. Basically, those coming in wake up stroke, because they like those who are attempting this webinar for first time, which who are not our Maro students, they may not understand it because if somebody comes to you with a wake up stroke, like they went to sleep at night, in the morning they wake up with a weakness, you don't know what time it is onset. So that was finally designed to rise based on an MRI. That is one indication to directly go for MRI. Then you do a diffusion flare mismatch. If there's a mismatch between diffusion and flare, in certain scenarios, certain circumstances, you can lyse the patient. That is what the previous guidelines. So 2026, actually speaking, there are 3 additions. In 2 additions plus the old guidelines on wake up is remaining the same. So basically, so this is a basic what happened in the wake up. So wake up stroke basically again the guidelines remains the same only. Yeah. So wake up stroke, basically the guidelines remain the same only. Like you can see that those coming with a wake up, a stroke where they get up from the bed, we don't know what time it started. In such scenario, the most important thing is you have to ask somebody like the patient's wife or someone who has slept the patient. They might see the patient when going to toilet in the night, coming back. That can also be taken at the time of normal sometimes. So you have to re-ask again. And all wake up doesn't need MRI. What I had seen is many of the wake up, when they come to casualty with the wake up, directly go for MRI. But you have to ask what was the last time seen normal. If last time seen normal is within 4.5 hours, you should take it as a normal stroke. No need of MRI. You can directly lysis CT. But if last time known is before 4.5 hours, suppose somebody got up at morning 5 o'clock and with a stroke of right side, and his last seen normal was around 1 o'clock. It's just 4 hours from onset, last seen normal. There is no need of MRI. You can directly take a plain CT, lyse the patient, then later decide on angio, like normal stroke. But if that patient got up at 5 o'clock and last seen normal at 10 o'clock, then you don't know what time stroke will start. At that scenario, you should go ahead with an MRI protocol to find out diffusion perfusion mismatch. I mean, diffusion flare mismatch. What I think is there are 3 caveats in this. One is, you look here, the same guidelines was there in the previously also. It should be smaller than 1/3 of MCA territory. So there are 2 things. One is there is no you look at this guideline, there is no proper thing on posterior circulation. They're telling about MCA. Posterior circulation again, it will fool you sometimes. Posterior circulation is always tricky. But still, what we can take is a diffusion flare mismatch and deficit is matching. You can lyse. But in MCA territory, if it is more than 1/3, the entire MCA, if you take it as more than 1/3, if you lyse, the risk of bleed is much higher. And in the trial which was done, they had not taken such patients. So that is why it should be less than 1/3 MCA. That is one caveat you should know. And second thing is, you see the last part, no marked signal changes in flare. The previous guideline 2019, it was no changes in flare. That means any change in flare, better not to lyse, was previously what they were communicating. But they made it much clearer. Actually, that was not they meant to communicate, but it became when it came in the guidelines, it was looking like that. Because both the guidelines were from same study. There are 2 studies which was done on wake up. Both actually did the same way. No marked signal. That means flare changes can appear, but it is not fully evolved. Then you can take it for lysis. So there is no change in the wake up guidelines up to 4.5 hours from the onset. Now this was the old guidelines. You can see that again, time of onset more than 4 point last zone well, and who are diffusion smaller than 1/3. Again, that was there in the previous. No visible signal change on flare was previously there. Now they made it no market. That makes it better communication, I feel. That is the only thing which was there. So that was a thing in extended window in wake up. And one more thing they are suggesting is that there's a new change is happening. These 2 things are the new things. One is those again wake up or unknown onset. They came to you, suppose the patient has last seen normal is 12 o'clock. And he woke up by 5 o'clock. And patient is coming to you by 10 o'clock. So from wake up, it is more than 4.5 hours. Now you cannot go with MRI. Such patients previously we cannot lyse. Now such patients can be lyse using automated perfusion image. And suppose their stroke symptoms are within 9 hours from the midpoint of sleep. They wake up at 9 hours from the midpoint of sleep with stroke symptoms. That means, suppose the patient awake from a stroke symptom within 9 hours from the midpoint of sleep. That is what patient is when to sleep at 9 o'clock. 9 o'clock, and he slept for 6 hours. Midpoint of sleep is 3 hours from the time he went to sleep. From there, 9 hours. That is what they meant. Then you can take it for lysis, and 4.5 to 9 hours from last seen normal. That means the time when the patient wake up with stroke, that is from 9 hours from the midpoint of sleep. And from the time patient woke up and patient presented to casualty, it is more than 4.5 hours. Suppose a patient, the midpoint of sleep was at, suppose it is 12 o'clock, and patient is presenting you by 10 o'clock, morning 10 o'clock. patient's midpoint of sleep was 12 o'clock. That means the onset of stroke, onset of symptom, which they notice in the wake up, is more than 9 hours. There you cannot use it. That is what basically it understood from it. And if it is somebody who woke up from the sleep within 4.5 hours, you can use diffusion perfusion mismatch, diffusion flare mismatch. But if it is more than 4.5 hours, you should go with automated perfusion image. And Partha, you were telling that your hospital was having perfusion image. So whether you were doing it because they are commenting about automated perfusion image there.
Yeah, we don't have the automatic software. The radiologist will look at the perfusion image and tell us whether there is any salvageable tissue available. We have a CT perfusion available, and many of the times the issue is that the the radiologist at night may not be that much well versed with the perfusion imaging, so they may not correctly tell us regarding the salvageable tissue. So it is very difficult in our scenario.
Yeah, actually, our new CT machine also has perfusion, but when I was discussing with our neuroradiology, he was telling that perfusion imaging, two problems are there. One is when you discuss with automated perfusion also, there are different softwares.
Yeah.
Calculation, different softwares, algorithms are different. So different softwares yield different algorithms, different values. Second thing is visual evidence is also sometimes misleading. That is one area which we still need to wait
There
and
is no standardization in the imaging software, basically.
So Chandu, what do you feel like going to aggressive in such scenarios?
So these are all aggressive treatments. See, the extended window, 4.5, more than 4.5 hours presenting to you, and not knowing the time of onset. So the latest guidelines tells us that the perfusion-based images has come into play for lysing the patient. So there should be a dedicated radiology team and the software that should be available to all hospitals for looking for the perfusion mismatch or diffusion perfusion mismatch. So I think most of the hospitals, it is not practically possible to have this automated perfusion imaging. So that is the risking point of the latest criterias.
Yeah. And somebody asked what is automated perfusion. Automated perfusion is basically a perfusion image with your MR perfusion is done. And a software is there. That software automatically analyze it rather than your visual evidence. And that will give you what is CBV, what is MBV, and what is a penumbra, what is a cortical blood flow, what is the time, everything that they will Tmax, everything that software will give you. And that will tell you how much is the penumbra, how much is the core. That is automated perfusion image. While the visual evidence also you can use to tell, but that may not be accurate. That is what automated perfusion imaging means.
It gives you the salvageable tissue, the how much the tissues are alive. So this is a tissue-based diagnosis. Actually, this automated perfusion images are tissue-based diagnosis. So that gives you the exact tissue which is alive. So the penumbra, area of penumbra, they'll help to guide you. That is what
makes our life more difficult. Now, if the patient comes to you within less than 24 hours with stroke, if you don't have this kind of facility, you may have to refer the patient because we don't know whether the patient can be thrombolyzed or not in such scenario.
Yeah, if feasible and affordable, you can refer to center which these facilities are there. That is a basic takeaway issue for a practicing physician because you have to give the options if they are going to a center with. But as much as I know, none of the centers nearby our hospital is having automated perfusion images. So that is a third part. That's the last guideline. That is another thing which is so much confusing in practically in our scenarios. What they're telling is that is for the practically non-wake up patients. So somebody has a large vessel occlusion from 4.5 to 24 hours. So it is outside the normal window, but he has LVO and cannot be taken for EVT. Either patient is not stable for taking for EVT, or the patient has some other problems which doesn't allow it. Maybe some tortuous vessel which cannot be. They attempted an EVT, they cannot proceed it. Such scenarios. Sometimes it happens. We attempt the EVT, but you cannot proceed it because the clot may not be, maybe a calcified plaque may be there. You cannot be maneuvered with the tortuous vessel. In such scenario, you can offer them. That is what the last part is. But again, you are going to lyse a large vessel with an extended window. If there's a salvageable ischemic penumbra, Again, the salvageable ischemic penumbra can be calculated. One method is perfusion image. Second method, I think you can still use your Dawn criteria, a clinical radiological mismatch can be used. Up to 24 hours Dawn can be used. When you have that, we will discuss when we go to the EVT. And even a perfusion or a plain MRI clinical radiological mismatch can be used. But if you see, interestingly, in the extended window for wake up, they are not mentioning about clinical radiological mismatch. They mention specifically for perfusion image. What do you feel like in that is one thing I noticed in that part. What do you feel like? That is what I made out. What you both felt from the first cadence, like whether you should still go for clinical radiological mismatch.
The thing is that the easy way to remember is any patient who is having a diffusion flare mismatch within 24 hours, I think it helps us to remember that the patient can be taken for thrombolysis. Only thing is that the perfusion comes into play and then we are in a difficult scenario. If you require a perfusion study, then we may not have that facility. That is the issue.
Chandu, what is your opinion on that?
See, I'm into like, if you know the time period within 4.5 hours of onset of symptom, MRI showing diffusion flare mismatch, go for lysis. That's it. See, CT perfusion and all nowadays becoming a little complicated. So, many hospitals, they don't have the CT perfusion images and all this type of software-based automated setups. So, it clearly tells us that there is a 2A, 2B evidence, right? So we always has to go for the class 1 evidence, which is better for the patient. And patient having a large vessel occlusion, possibly if the patient within 24 hours extended more than 4.5 to 24 hours, where the patient cannot be taken for a LBO, CT perfusion sometimes comes into play because if there is a salvageable tissue, we can go for lysis. See, if the patient having a large vessel, not able to go for endovascular therapy and CT perfusion showing salvageable tissue, I think it is better that we can go for lysis. That's what the 2B guidelines tells us. Is it so?
Yeah, but I was actually going through all the studies which they had mentioned next in window, as well as I was searching in some studies on diffusion flare mismatch. What I find out was really interesting. What I find out is that uh, diffusion flare mismatch can be included only for wake up stroke. In a non-wake up stroke, diffusion flare mismatch, they are not suggesting for taking for lysis. Suppose somebody came to the outside window, a patient has not a wake up stroke, but patient came outside like 5 hours, you still see a diffusion flare mismatch, but guidelines are telling you cannot lyse that. Because why it is like that is there have been no studies into that, not much detailed studies into that. Studies was done on wake up stroke only. Whether you can apply it on a normal stroke, I think it is difficult scenario to explain because theoretically it should be fine, but practically they are not giving any proper guidelines on that.
I think for the students to remember, we can divide it into a patient who is having a LVO and who is having a non-LVO stroke. I think that easy to remember. If there is LVO, then the guideline changes a little bit.
Yeah, again, what I was telling about the first part, like wake up stroke and non-wake up, whether you can take diffusion flare mismatch for external lysis. So, and the second thing is like again, like what happened practically. Suppose our patients, those who are not willing for EVT and LVO, very less likely they will agree for IV thrombolysis also, especially when they present after 4.5 hours. And in such scenario, if you like, suppose you have a large LVO and outside 4.5 window, they're not willing for lysis and thrombectomy. When you discuss with them and you take for a lysis, I practically feel that will high risk of bleed. You have to definitely explain, not just 2B. I feel it will practically high risk of bleed. It will be. That is practically one problem we will going to face because this will happen. Like some patients will come like 5 or 6 hours of window. they have an LVO, we offered them thrombectomy, they are not willing, then whether we should offer them a lysis.
Difficult in our scenario.
Yeah, I think what we can do such scenario practically is a clinico-radiological mismatch. Don't criteria. Flare, suppose flare there is a small infarct, but clinically there is a large infarct. Then you can, I think you can definitely give at least an option. Or like you were telling, like diffusion flare mismatch, that also can be included in such scenario. I don't know, like this is a difficult, we have to see practically what is going to happen because a new thing.
See, now patients, bystanders are all very aware that lysis is within 4.5 hours.
Yeah.
So suppose if it is more than that hour they presented and we lyse the patient and patient is presented with bleed, then it becomes other legal problems.
Yeah, other legal
Although
problems.
they are not very aware of, we are aware of all these guidelines, but I don't think the law of court or the bystanders or they're not much aware of the class 2, 2A, 2B evidences. So it's always safer side within 4.5 hours of presentation. We are aware that the time period is within 4.5 hours, the extended time, and there is a diffusion flare mismatch. Go for lysis. If it's a large vessel occlusion, then we have to go for an EVT. And
yeah, I think what practically feasible is like you're telling, like if they present within 4.5 to 24 hours, rather than pushing them for lysis, it's better to push for thrombectomy.
Thrombectomy, correct.
Yeah, if it is a large vessel occlusion, then it makes our job very easy. Straight away go for EVT. If it is not a large vessel occlusion, then that 2A guideline comes into picture. Then we are in a scoop.
Yeah, as Dr. Parthan told, we have to divide into LVO and non-LVO. So with the LVO, just think of EVT, and the non-LVO, which should think of lysis and the time period and the presentation, what the patient present to you. So that is how we have to go forward. I feel so.
Yeah, I'll just clear it. Basically, you have two scenarios of extend window. One is with wake up and second with non-wake up. In wake up, it is very clear. If the patient comes with a wake up from less than 4.5 hours from the wake up, you use MRI, diffusion, flare mismatch. You lyse the patient. That is one scenario, very clear. Second scenario, again wake up. The patient came to you after 4.5 hours from wake up. Then you have to go with a perfusion image to see a salvageable tissue. You can offer lysis. There is the first two scenarios. Clear? Now the third scenario. Third scenario is a non-wake up stroke. Non-wake up stroke, if it is LVO, if the patient cannot be taken for EVT, like after 4.5 hours, what you're talking about extend window. If they're coming in extend window after 4.5 hours, patient cannot be taken for EVT, then you can offer lysis with high risk. The risk is slightly higher, not very high, it is slightly higher, it is 2B evidence. But again, the patient, so basically anyone who present outside 4.5 hours, if it is a non-wake up, not a wake up, only LVO can offer lysis. If it is not an LVO, there is no option of lysis. So LVO, you have lysis as well as intervention in 4.5 outside, 4.5 to 24 hours. And always in LVO, EVT is always better. Thrombectomy is always better. If in chance you are unable to do thrombectomy or in chance you are in a peripheral center, that is what they meant. They meant the patient cannot be transported. The patient is a peripheral center. Then there also you can offer lysis. If suppose salvageable tissue is there. Now it is clear, I think. Any doubt you can message. We'll just clear it because it's a very confusing area.
It was confusing for us also when we read it for the first time.
Yeah. Please, can you repeat what to be done if wake up stroke more than 4.5? So basically, more than 4.5 hours to 9 hours from wake up, you should go with either MR perfusion or CT perfusion, not diffusion flare mismatch. Diffusion flare mismatch only for less than 4.5 hours from wake up. Clear? Wake up, there are two scenarios. One scenario is within 4.5 hours from wake up. There you use MRI. 4.5 to 9 hours, you use CT perfusion or MR perfusion. Next scenario is non-wake up or wake up, whatever it is, an LVO. LVO in outside window of 4.5 hours up to 24 hours, best is always EVT or thrombectomy. If thrombectomy cannot be taken, such scenario, you can still offer a thrombolysis but the evidence is much less. But more importantly, you should be make sure that salvageable tissue is there. So there comes one problem. Like patient comes to you, you explain everything. By the time patient take decision, especially this is a difficult scenario, the patient may not be willing for EVT, or patient might have transferred to your DSA lab. They manipulated for many time. They were not able to cannulate, or there is other issues are there. There will be lapse of 1 hour, 2 hour. Now you have to again re-image. You cannot tell the salvageable tissue which was there 1 hour prior will be there right now. 2 hour prior will be there right now. So there you have to repeat an image and then decide. Again, it is a complicated scenario. Because the risk will be very high if you are directly lacing. Correct, right? Right, both of you. Like I feel that will be the only practical possible thing.
Yeah, the one scenario that I faced during my training was one patient had very severe LVO, not and he had some cardiac issue. So he was unstable to be shifted to a cath lab. So that time these guidelines were not there, so I didn't go for thrombolysis. But when we were discussing in our academic meeting, our stroke neurologist told that actually we can think about thrombolysis in those scenarios.
Yeah, actually, that will be a very difficult scenario. So, like, how will we explain all those things to the patient?
Yeah, that is very difficult. It's
We
only
like,
for academic discussion most of the
yeah,
times.
for a well-educated, it will be okay. But
Yeah.
in our scenarios, what we face will be those who will not understand these terms. So actually, fairly difficult. We have to only the time will prove what we are going to do with this.
Another point I think the students will confuse is one is the midpoint of the sleep. So they have to like understand that midpoint of sleep because there are two times they have written either from the midpoint of sleep or 4.5 hours from the wake up. They may get confused by both these terminologies.
Yeah, I'll just make what they mean. The first statement is, suppose I'm giving you a scenario. The midpoint of sleep is at 12 a.m. He slept sometime before. I don't know this time before because I'm bad in mathematics. So just take it as 12 o'clock. Midpoint was from the time he went to bed and time he woke up. In midpoint is 12 o'clock. So he woke up by 9 o'clock, before 9 o'clock. That means from the midpoint, it is within 9 hours with a stroke. There you can offer it. But suppose you wake up by 10 o'clock or 11 o'clock or 12 o'clock, you cannot offer it. That is what the midpoint sleep. And remember, this midpoint of sleep is not for normal within 4.5 MRI based criteria. That is only for automated perfusion. This area is very much confusing. So basically, wake up. If they woke up within 4.5 hours from the wake up, suppose he woke up by 9 o'clock and he's coming to your casualty within 4.5 hours from 9 o'clock, then there is no confusion. Directly MRI, diffusion layer massage lysis. But if he woke up by 9 o'clock, midpoint is at 12 o'clock, and he comes to casualty after 4.5 hours. There is where you are going to use all those things. I think now it is clear. Okay. So that was about extended window. Altogether, extended window you have to come. For wake up, more than 4.5 hours in the wake up, diffusion mismatch cannot be used. Within 4.5 hours only, that is where entrance question can come for you. Somebody who wake up from within 4.5 hours, you can use diffusion pair mismatch. More than 4.5 hours, up to 9 hours, you will use a perfusion image. So this is one more thing. Less than 1/3 of MCA is the same. One more point is, if you look into the wake up trial, previous guideline it was written just below the box of the guidelines. NIHS more than 25 are not included in both of the studies for wake up. So again, NIHS more than 25 is not directly put on the guidelines. But what we have to assume is that somebody comes to you with an NIHS more than 25 wake up, the risk will be definitely going to high. But it is not a contraindication as per the guidelines. But less than 1/3 of MC is practically a contraindication. So this is a classical case which came to me last month. Which one you want to repeat? Shazia? Right. We'll repeat after this case. Okay, so basically, there's a 74-year-old male present history of weakness of right side with aphasia on wake up at 6 a.m. Came to casualty at 8 a.m. So he is in the window, like 4.5 hours from wake up, but he went to sleep at night 10 o'clock, so we don't know what time it was onset. Classical wake up scenario. He is conscious, obeys command, aphasic, but predominantly motor aphasia. Because he obeys simple command, he even was obeying the cross commands with the hand. So right side grade 3 by 5 upper limb and lower limb, gaze preference to left side, and right facial palsy. So he has significant NIHs. It's not a minor stroke, it's a significant NIHs. Again, the patient is in wake up. So what image you will do? MRI or diffusion, which will do? But MRI diffusion or perfusion image, which one will do? You are going to see within 4.5 hours, there is no confusion, perfusion is not needed. That is where the confusion happens. Perfusion is required only if from the wake up, if it is more than 9 hours. I mean, more than 4.5 hours. Here, the within 4.5 hours from the wake up, 6 a.m., 8 a.m., 2 hours. So you can directly go with MRI flare diffusion protocol. Always think you have to include an SW also or a gradient image also, because it can be bleed also. Bleed will be missed in diffusion. Bleed also will show diffusion restriction. Bleed may miss in flare image. So always think, even if you are taking diffusion flare, always cross check with SW image. If you are going with MRI protocol, SW or GRE, whatever it is. So we went with an MRI, and this is the diffusion MRI, and right side, this is the left side of you is a diffusion, and right side is ADC. So you can see in the left insula, there is hyperintensity, which is diffusion restricting on the left side. Clear? So again, you can see this is a capsuloganglionic cut again. So there is a small, very small, subtle, maybe 1 millimeter thing in the left caudate. It's not involved in the entire caudate, a very small thing. Again, you can see, so you will calculate the aspects as caudate, internal capsule, lentiform nucleus, then insula. So here is insula is involved. Caudate, you can take it as 1 point. Then M1 is involved, M2 is involved. So you have 3 points. Then this is supraganglionic cut. You can see M4 and part of M5 is involved. You can take 5. So aspects comes around 5. But one point I want to consider is that even if you take aspects around 5, here there's a small dot. I don't take it as a serious involvement of caudate. Entire caudate is not involved. So this is the flare. You can see there is nothing has been evolved in the flare. The classical diffusion flare mismatch. You can see here was a flare diffusion changes, which was there in ADC. The insula also it was there, it is there in ADC. Again, higher cortical also, your M4 and M5 also there, which is not, nothing is there in the flare. There is a classical diffusion flare mismatch, isn't it? So my question here is, sir, this is 4.5 wake up, or this 4.5 hours from the wake up. If it is 4.5 hours from the last seen normal, there is no need of MRI. You can directly go CT and take cases. Take it just normal case. The confusion, the problem from last seen normal, it is more than 4.5 hours. So my question here is, you were discussing like less than 1/3 of MCA, less than 1/3 of MCA. So how will you make out it is less than 1/3 or more than 1/3? Anyone has any opinion? How will you make out this is less than 1/3 or more than 1/3 of MCA? Dr. Dolly, any opinion you have? Dr. Smriti? Yeah, excellent. On basis of aspects, you can tell, but it is not a conclusive thing. That is what I was going to tell. Like NHS, you cannot tell less than 1/3 and more than aspects is one thing. See, that is where aspects also will differ you. Like you see, where aspects this comes, this small dot will counts in aspects. But practically, I feel this is probably some small bit of embolus which has gone there. So practically you are not going to treat it. It is not going to alter, even if that is where the problem of aspects also comes there. So usually more than 1/3 of MCA means aspects less than 5. By seeing the image, like clinical symptoms, that is why you can have clinical radiological mismatch now. Like some scenario, you will see large clinical deficit, but MRI doesn't show much aspect. That is a classical clinico-radiological mismatch that tells you based on your Dawn criteria that there is a significant penumbra is there. So symptoms never counts in calculating. Your imaging-based calculation only. One is by aspects, if less than 5, it most likely to be more than 1/3 of MCA. Second point is, which I went through many articles. I find, not articles. I have discussed many and articles also that like MCA supplies basically a superior division and inferior division, and it has a perforated territory. These are 3 branches. So suppose somebody has both superior division and inferior division involved, that is definitely more than 1/3. If somebody has a superior division plus significant involvement of your capsuloganglionic area, that is again more than 1/3. Somebody has an inferior division plus more capsuloganglionic significant involvement, that is definitely more than 1/3. So that is one practical area you can see from image. If somebody has an involvement of an inferior division or a superior division plus basal ganglia, or somebody has involvement of inferior division plus superior division, or somebody has involvement of all 3 areas. So these are more than 1/3. So you have 3 areas: superior division, inferior division, and perforators. Again, the perforated territory, you should use your logical common sense that this is a very small infarct. So we'll come back again to the image. This is temporal lobe, left temporal lobe, right? The left temporal lobe is supplied with inferior division. So inferior division, there is no infarct. So inferior division is not involved here. And you have a very small thing on this. I won't count it as a significant involvement. If there is a large thing on the caudate and the lentiform, I should have taken it as involvement of a perforator. And superior division is definitely involved. So this patient has only involvement predominant in superior division. Even the insula comes as part of superior division. So you can take it as predominant involvement in superior division. And even the aspects is 5, borderline. Because the 5 count came because you included this caudate. This caudate is, I feel it is a very small infarct. So that is where always in neurology, you have to use your practical sense when you're managing patients rather than going with strict protocol. That is the difference between somebody who's a non-neurologist managing stroke and neurologist managing stroke. So, because you should know the physiology, that is why you are going to read your physiology, how to correlate physiology and anatomy with your practical aspects. That is 2 points you can make out whether it is 1/3 and more than 1/3 or less than 1/3. That I'm telling you is I searched lot of places. I could not make out a proper idea of that. Then I discussed with one of my neuroradiologists. Then I checked in few guidelines. Then I discussed with few stroke fellows. Then that is what I made out, this one. And there are some studies are there based on this also. So what do you think, Partha and Chandu?
Exactly. Basically, the MCA has, as you told, the superior and inferior branches. There is something called as dominant branch of the MCA. Sometimes the superior division may supply some parts of the inferior division also. Sometimes the inferior division may supply some parts of superior division also. In those scenarios, you can see an extensive changes in the MRI, even though only one of the branches may be involved. So this is a tricky situation, as you have discussed. There are no strict ways to measure the 1/3 of the territory. The easy way is just as you mentioned, you look at what are the areas that are involved and look at the aspect. Other thing is if you have an angiogram is showing stem of the MCA occluded, most likely more than 1/3 will be involved. So those are the easy ways to remember.
I think looking more for the aspect score, no? Aspect is less than 6. So
practically what all the
easier.
Every guidelines what they're telling is aspects less than or equal to 5 is considered as more than 1. But the problem of aspects is again like this case typically took because of that. It's a very small thing. If you include this, it will be definitely below 1/3. You cannot lie such patients.
You have to use your common sense.
Yeah, we have to that time you have to use your common sense and think what will happen. And again, even if sometimes what happens is MC M1 stomach occlusion also, if you have good collaterals, the infarct may not be developed.
Yes.
So such scenario also you can practically visualize aspects and tell, or you can use this case is where the aspects looks like 5 more than 1/3, but I feel it is less than 1/3 because of these factors. That is why I purposefully taken this case because this was a confusing thing for me also when the patient came to me. So
only thing the chordate would have been the embolic one. So
yeah, maybe a
so
small,
possible.
a small
Just move.
so
Like funny dots
everything has went
in
and
that,
hit there.
The patient doesn't read the guidelines, so the infarct may be spread out. In those scenarios, it will be
Yeah,
difficult.
what I thought is, you see this area, this is actually head of caudate,
Yes.
and this here somewhere here is a tail, and somewhere below is the body. So head of the caudate is actually supplied by ACA. It's not the MCA. So if you see the angiogram, you cannot see left IC. Right IC is there, left IC is not there. So most probably some embolus has gone from there, and that has went to AC and caused that caudate. So that actually that part of the head of the caudate is not a part of MCA circulation. So you
Yes.
cannot take it as 1/3 of MCA inclusion.
Possible. Artery to artery embolism.
Yeah, because again, this is head of caudate. Head of caudate is more likely to be an ACA supply, not MCA supply. But there is overlap. It's not always for everyone. It is like that. It can
moreover,
overlap.
it looks like an embolic event only. Like that embolus has lodged on that caudate. It's like a dot, a funny dot.
So again, I'll show you one more thing for students. See, he has a left IC occlusion. So he came in wake up, we lyse the patient. So he has a diffusion blur mismatch, we lyse the patient. So that fits to, so more than 1/3 means superior plus either superior plus inferior. See, take it as 3 areas are there. One is superior division, one is inferior division, one is your perforators. A significant perforator involvement with superior, you can take it as more than 1/3. Significant inferior division involvement in MRI and significant involvement of lenticular right or the perforator areas, then you can take it as more than 1/3. Out of the 3, at least 2 involved. Any 2. So that is a practical thing. Again, it doesn't mean always to be strict on that. You have to use common sense sometimes, like this patient. Stem of MCA is what? MCA stem means the ICA comes there and divides in MCA. That basic horizontal area of the MCA, the proximal part of M1, that is known as the MCA stem. So we lyse the patient. Patient doesn't have much improvement. What will you do? Take for thrombectomy. So I'll show you one more image. I think it is there. Yeah. So this is not a classical perfusion image. This is known as a poor man's perfusion, something known as ASL perfusion, arterial spin label perfusion. The technique of this is you will label the hydrogen atom in the blood, and MRI will pick the hydrogen atom in the blood or the water in the blood. That acts like a dye. That is a basic principle of ASL, arterial spin label perfusion. You don't need to give dye, and it is much cheaper, but it is not a gold standard thing. But you will get a lot of idea. See, in the left ICA, you can see the infarct are much smaller. See, it is very small infarct. But you see the perfusion, entire left hemisphere. This is PCA territory. This is part of ACA territory. Entire MCA territory is deficient of blood flow. So if you leave it, the patient will develop a malignant MCA because the stroke has not developed. This tells you that there is a salvageable large huge penumbra. So this can again be used practically because in our resource limited settings, they can still be used practically. But again, ASL perfusion has lot of artifacts, lot of issues with that. But still, clinically, the patient's left IC occlusion, we can include this. So this is the entire penumbra. You have possibly this much areas where you have the core was there. That also not developed in the flare. So it is very, very hyperacute. He has a very large infarct, and out of that very small area had diffusion changes, which was not developed in the flare. So that means the entire left MC is going to get infarct. But he has not even a core has properly developed. So there's a very high chance that he will improve. So we have taken the patient for thrombectomy. And actually what happened is the patient bystanders were initially not willing. They had a lot of delay, and we did thrombectomy, and patient had bleed later because they delayed for a lot of time. So then that patient survived after some time. But if they would have agreed for initially post-lysis direct thrombectomy was a plan, but around 3-4 hours they wasted. Then we have to take another MRI and then taken for thrombectomy. So that was again that is a tricky scenario is going to happen practically because they initially will not take some time for discussion. Then later they will. You both might have experienced that for
Exactly.
this.
Yeah. Every neurologist would have experienced that. Time is brain.
Yeah.
Each second you waste, the chance of getting a normal patient is less.
Very few scenarios in neurology. Time is brain or time is gold. One is stroke. Very few scenarios. So stroke is one area where time is brain or time is gold. So
yeah, and again, that concept of core perfusion, which we were discussing right now, is going to change with the next slide. From when we start discussing, the things will again change. Okay, so the extended window, this is a summary of extended window. If patient comes within less than 4.5 hours wake up, diffusion blur mismatch, you can lyse. And 4.5 to 9 hours from last known well, that is patient woke up after 4.5 hours from, a patient came after 4.5 hours from the wake up, then you need perfusion image. More than 9 hours from wake up, if no LVO, medical management. With LVO, whether it is wake up or non-wake up, you can offer EVT directly. If EVT is not eligible, then you can lyse. Like the Partha was telling, when scenario where patient is not stable to shift for thrombectomy, then you can offer them, but it always have to be explain the risk, because these are new things. We don't know what happened practically in our scenarios, because we had seen like our scenarios are slightly different from what we see in eukaryotes. So you have to, that doesn't mean you have to call it a contraindication. You have to explain, because again the risk is too big. So that is what the summary of extended window. But what I have to tell is, extended window, there is not much change practically. The change is basically perfusion image, and second is LVO with non-wake up or wake up to 24 hours you can lyse. If they are not willing for EVT, or patient is not stable enough to take for EVT, and there is a salvageable tissue. That is only change. Otherwise, it is same. I think now you guys understood it. Any doubt, you can message. I doubt the patient slept at 8 p.m., woke up at 6 a.m. with deficit, present in the hospital 11 a.m. So from wake up, it is 5 hours. So 4.5 hours post. Now it is 5 hours, no? So for first wake up, can we do perfusion in this scenario? So it is in this scenario, somebody has asked that patient slept at 8 p.m., woke up at 6 a.m., present to hospital 11 a.m. So from wake up 6 o'clock to 11 a.m. it is 5 hours. So it is more than 4.5 hours. Then perfusion only. Midpoint sleep is 1 a.m. So more than 9 hours from midpoint. So no. More than 9 hours from midpoint is a wake up. See, 1 a.m. is a time of midpoint. His wake up time is 6 a.m. So it is 5 hours from the wake up. The wake up time should be less than within 9 hours. Understood that? Why they created that criteria is, the window is from 4.5 hours to 9 hours. You are going to lyse the patient from the 4.5 hours of wake up to 9 hours. So you don't know. Suppose somebody is going to bed by night 10 o'clock. He was alone. By next day evening, somebody is seeing him lying down there and then bringing to hospital. That also can happen. Such scenario, you don't know like whether it is more than 9 hours or not. That is why they kept it like that. This is a classical scenario. From 6 to 4.6 to 11, it is 5 hours. 6 to 1 a.m., that is a midpoint, it is 4 hours. So it is the wake up time is where should be within 9 hours. Understood? So other specific scenario, CRIO is one scenario, previous INA question. CRIO previous INA question was they asked for lysis. But now also lysis is there, but evidence has reduced. They have kept it as uncertain. Previous guideline 2019 has not mentioning about CRIO, central retinal artery occlusion. But again, the problem is the ophthalmologist has to come and diagnose it, because CRVO, BRVO, we cannot lyse. It will bleed. So I don't know how much time it will take to do that. What is your area of experience with CRVO coming to casualty? CRVO coming to casualty.
By the time it is diagnosed, it is most likely out of the window period.
Chandu, have you had any experience?
I don't have any experience of.
I had one patient again came with the CRIO, but like Partha was telling, like he came to casualty around 4 hours. By the time it has been evaluated, because it will take time. You have to see the fundus, you have to finalize. But again, it is uncertain. So what we can offer most of the times is a massage of the eyeball. Sometimes they will give mannitol and Diamox. That is what is right now possible, because practically, because they won't come in that early most of the times. And sickle cell anemia, again, the criteria is same. DAPT is not a contraindication. This is actually cortical microbleeds. This is actually same as what is there in the previous guidelines. There is no difference. More cortical microbleeds more than 10 is a relative contraindication, can be considered relative. But again, you have to think that doesn't mean all patients you should go with MRI. There is a previous MRI showing cortical microbleeds, then you may think, because there is very less studies on this. Again, cortical microbleeds is a scenario in India very common than other places, because we have a lot of small vessel disease, poorly controlled diabetes, poorly controlled, especially in Kerala, poorly controlled diabetes, poorly controlled hypertension, obesity, all those less exercise, all those things add up to the CMPs. Again, the area of CMB is very important because hypertensive CMB occurs in the capsular ganglionic area. But if you have a cortical, particularly there's a superficial siderosis like this, very superficial, like in SAS. Those things you have to be very, very careful because that means it may be a amyloid angiopathy. Amyloid angiopathy, again, lysis is better to avoid. So, what is your opinion about this, doctor? Both of you, like cortical microbleeds.
The SWI sequence should be there in all MRAs that you take before you lysis. And again, as you told, we see a lot of microbleeds in the capsular ganglionic region, pons, midbrain. So those may be related to uncontrolled diabetes or hypertension. So in such scenarios, maybe a higher risk is there, but not as high as when you see in the cortex, maybe in the but the issue is that by the time you measure the number of microbleeds, more time is getting wasted. So, and if especially in the night, the number of cortical microbleeds that is reported by a radiologist, he will not tell you how many numbers are there. He'll just tell you there are some microbleeds.
Yeah, exactly. And again, that is why many times a CT-based protocol is much easier for lysis. What they're telling is if there's a previous MRI showing cortical blind means more than 10, that, like, suppose who is already diagnosed, then you can, I mean, it's not a complete denial. It's always.
I have never seen a report where they say that there are so many numbers of microbleeds are there.
Never.
I have never seen a report. Have you seen, Dr. Chandu?
No, I have also not seen any reports like no.
They will just mention microbleeds. That's it.
Yeah.
Number is never mentioned.
Correct.
Yeah, that's it. I think again, amyloid angiopathy is a condition where you should consider not to lyse practically, even though it is not there in the guidelines.
Especially older age groups.
Yeah, older age group.
That is what we have to see. Age is to play that.
Yeah, I had one case recently. He came with not recently, 1 year back. I think we had discussed. I had discussed with you both. I think he came with left-sided weakness. There was some jerks. He was a diagnosis of amyloid angiopathy. MRI was actually showing carry. So we cannot take away for lysis. They will bleed. So we managed conservatively and he improved. Weakness improved. So this is what CRIO is disabling visual deficit. It's again uncertain. Doesn't mean it's contraindicated, uncertain. Previously high burden, demonstrated MRI. Usefulness again uncertain. It is not contraindicated. That is what you understand. See, cortical microbleeds more than 10 is a relative contraindication, never an absolute contraindication. So you have to discuss again with the bystanders. There is chance of bleed is much high. Then with the discussion of the bystanders only you can decide. Again, in the non-disabling strokes, even if minor strokes you can discuss, and sometimes you can stop lysis sometimes because this will be more harmful. Do no harm basically. So that is about a specific scenario. So we discussed about the external window lysis. Basically, external lysis, wake up stroke within 4.5 hours, MRI lysis. If it is 4.59 hours, then you go with perfusion. If it is an LVO, whether it is wake up, non-wake up, doesn't matter. More than 4.5 hours and cannot be taken for EVT, then you can offer lysis with the evidence of 2B, and you have to make sure there is alveolar brain tissue. That is what from the external window lysis. Now, the most important area and most difficult area, there is a contraindication lysis where a lot of changes happen in the new guidelines. So, coming to contraindications, the 2019 contraindication is much easier. So, whatever I had given the red is right now not a contraindication. So, CT extensive hypotensity more than 1/3 of the cerebral hemisphere is considered as a contraindication previously, now also. CT acute bleed, intraaxial neoplasm. Somebody who has a meningioma is not a contraindication. Intraaxial, inside the brain. So, extraaxial neoplasms are not a contraindication. But suppose extraaxial neoplasm has a bleed within, then it is a contraindication. It should be a contraindication because it comes under acute bleed. And suspected infective endocarditis or aortic arch dissection. That is one tricky scenario. Because most of the times infective endocarditis will be diagnosed after aortic dissection. If the patient presents classical chest pain and symptoms, we may. Otherwise, you will miss it unless you are not doing a CT angio. MR angio, usually you don't cover the arch of aorta sometimes. So that is somewhere you can miss. What do you have any experience with aortic arch aneurysms? I mean, aortic arch dissections.
Yeah, I had a recent experience. Patient came with the left hemiplegia. Patient was having slight restlessness. So he came within window period and he had ECG changes with BP was on the lower side. So we thought it could be a MI associated with the stroke. We could only do the CT plain because patient was slightly restless. We then took the patient for thrombolysis. After thrombolysis, did the CT angio. Unfortunately, it showed a large aortic dissection extending into both the carotids.
Oh.
So unfortunately, he was immediately taken for the repair. I think the CVTS had repaired both his coronaries because the dissection was so severe it was extending to the coronaries also. So here we couldn't diagnose the dissection before the lysing the patient. So such scenarios can happen. So when you get a patient with stroke with low BP, you should always be careful where there is any dissection associated with it.
Yeah, we had two patients. Like one was aortic dissection. He actually came with chest pain followed by he came to casualty chest pain. Then he developed sudden onset of weakness. Then actually we taken CT angio, and then I had informed our neuroradiologist, and he was there. He saw it, and he directly told there is an aneurysm in dissection. So we didn't like the patient. Another patient that was very interesting patient. He actually very obese young patient, very obese patient. He had history of breathlessness for last 3 days, and he came to casualty with severe breathlessness. And they had done a pulmonary angiogram which showed pulmonary embolism, massive pulmonary embolism. He was in shock. Then while after just finishing the CT, he developed weakness. Then did an angiogram. He has an M1 thrombus and pulmonary thrombus. Then we had our neurointernist along with cardiologist both us underwent taken both together. Initially, P was done, followed by initially MI. I mean, brain was done, followed by P. Both us. And patient survived, and patient had improvement, but there was some deficit. And later they went to, because of financial issues, they went to government. So such scenarios are always difficult to manage, difficult scenarios. So that too comes, and that and there is no guidelines to help you. You have to just go with whatever practically you want to do. And do you have any experience with?
See, some patients, what I feel they might present clinically with some interscapular pain. That is has to be suspected for aortic arch dissection, possibly. No, not always, but they can commonly present with the interscapular pain also.
Yeah.
And other things, as Parthan told, there can be hypotension. These things also has to be taken into consideration. And once we do what about the imaging part, which can rule out this aortic dissection, that we do the neck imaging as well as intracranial vessels. Neck imaging should not be missed. So
first time actually, that is where your CT angiogram help, because CT angiogram offers better angiographic images.
That imaging, more neck imaging, extracranial.
We love to do CT angiogram in window rather than MRI angiogram. Any confusion, we go with MRI angiogram. Otherwise, CT angiogram is direct. Stroke is there, we go with CT angiogram is better.
See, the hypertension part has a major role. So once the patient present to you, normally patient present with stroke with the hypertension, BP will be autoregulation. Because of autoregulation, BP will be higher. Once the patient present to you with hypertension, that there is a red flag. So that has to be considered. That's what I feel. So
yeah, again, there's a pain, interscapular pain, then pulse difference between limbs. These are the three things you have to look in aortic dissection. And one more thing is that when patient presents hypotension, one possibility is that they will have a large oscillator push. Hemodynamic stroke can occur. When the pressure improve, they will improve also sometimes because they have IC disease. So I have not started about the contraindication about the guidelines. I mean, this is all guidelines. I'm going to start with the new guidelines. So basically, these 5 things stands there, but the previous IC bleed is not a contraindication now. Ischemic stroke within 3 months is not a contraindication now. Severe head trauma within 3 months has changed to 2 weeks. And intracranial intraspinal surgery 3 months is changed to again 2 weeks. GA malignancy is not a contraindication. Active internal bleeding, non-compressible bleeding is still a contraindication. Bleeding diastasis is a contraindication. INR, PT, all these things are there. Heparin, they are not properly commenting in the new guidelines. I'll discuss about that later. LMWH, therapeutic dose within 24 hours was a contraindication previously. Now they are not mentioning about that. What they are mentioning is they have heparin. They're just telling about heparin. you have to check an APTT, PTNR. Then if it is normal, you can lyse. Again, the last part is almost same only. So I'll go to the new guidelines. The new guidelines, basically, these are the contraindications. These 10 contraindications, absolute contraindications. Risk is more than benefit, avoid lysis. These are 10 things. So basically, you take the first three things. These are image based. First is CT with hemorrhage, CT showing extensive hypodensity. Third is intraaxial neoplasm. So these three things are image. Next three things are surgical. You can remember like that. First three things are image. Next three things are surgical. Moderate to severe TBA, traumatic brain injury, within 14 days. Neurosurgery within 14 days. A spinal cord injury within 3 months. That is only 3 months right now, meaning both are 2 weeks. So 3 CT, 3 surgery. Then you have systemic things. Coagulopathy, so thrombocytopenia, infected endocarditis, aortic dissection, and last one is amyloid-related imaging abnormality, usually seen associated with treatment. As well as what we are discussing, like amyloid angiopathy, also a significant amyloid angiopathy diagnosed directly also can be related to can be contraindication. So basically, 3 images, 3 surgeries, and 4 systemic things. So these are the things which are absolute contraindication right now. In general management, you can actually watch. We have in the YouTube the videos there. You can watch from there. Yeah, grading of moderate. I'm going to discuss that. So that is the basic risk more than benefit. So again, CT with extensive hypodensity in the new guidelines, they are clearly telling what is this. If the density is greater than contralateral unaffected white matter, and you should be looking in a stroke window, not in a regular window. You should be looking the CT in a stroke window, where you can differentiate white matter and gray matter very clearly. In such scenario, if the hypodensity is greater than contralateral unaffected white matter, then there is a contraindication. And moderate to severe TBA means at least more than 30 minutes of unconsciousness and a GCS of less than 13, or evidence of hemorrhage, contusion, or skull fracture during the time of TBA. Such conditions, you should avoid thrombolysis. I think that is clear. This is the criteria for American Trauma Society criteria for mild, moderate, and severe. So moderate and severe, you should not take for thrombolysis. So what in guidelines tell is just 2 points, that is 30 minutes and Glasgow stoma score. And any hemorrhage, contusions, or skull fracture. Again, the coagulopathy, what they are telling is almost same. INR more than 1.7, PT, APTT more than 40, PT more than 15. Again, don't take this PT more than 15 practically. What happens is each lab, depending upon the solute used, so the solvent they use, this may change. So always look at the INR is a better thing to look at. The standard value may differ. So INR more than 1.7, APTT more than 40, and is unknown, though may be substantially increased harm and should not be administered. And recent use of warfarin or heparin, treatment as IV thrombolysis can be initiated before available coagulation test, should be discontinued if INR more than 2. So this is practically not feasible with an altiplase. What they're telling is about altiplase. What is there in the previous guideline also. So with an altiplase, you give bolus. Altiplase, what they're telling is you can initiate treatment, but practically, I don't think we can do it. What we can do is get the APTT, PTNR, bleeding parameters, if the patient is on warfarin or heparin. Heparin, I think it should include the LMWH also. But LMWH, it's difficult to manage. So what is your opinion on that, Dr. Chandu, and for the if patient is taking LMWH?
The tricky situation, I would rather avoid.
And Chandu? I think Chandu has some network issue. So actually, LMW is a very tricky scenario. I think we practically have to stick on to the old guidelines. Within 24 hours, therapeutic dose better to explain and avoid. But again, if APTT, PTNR is normal, you can still offer with high risk. Because they are not mentioning about LMWH clearly in this guideline. I could not find out anywhere. Then we had actually reversed with protamine and lysis one patient in our PG day. But that actually protamine reversal may not be complete sometimes. We reversed protamine, did an APTT, and got it done. And you can get done an APTT PTNR in 15-20 minutes. if you have lab nearby. So that is one possibility of severe coagulopathy. So basically, these are the basic contraindications. CT with hemorrhage, CT showing extensive hypodensity. This hypodensity should be greater than opposite white matter in a stroke window. And interaxial neoplasms, moderate to severe TBA, which is more than 30 minutes of unconscious and ECS less than 13, or contusion, hemorrhage, or fracture in the CT. And neurosurgery within 14 days, a spinal cord injury less than 3 months, coagulopathy, thrombocytopenia, infective endocarditis, aortic dissections, and ARIA. These are the absolute contraindication right now. For entrance point of view, now you should remember this. So everything else is not a contraindication. This is a previous contraindication where they mentioned about LMWH full dose 24 hours. That means BD. LMWH given BD dose, full dose within 24 hours. Apparent within 48 hours with abnormal APDT was also considered as contraindication. They were also not mentioning about reverting with protamine sulfate. Again, protamine sulfate is tricky in LMWH because it won't reverse completely.
I think in patients with impaired creatine and all those things, the effect of LMWH also will maybe prolonged.
Yeah, prolonged.
So better check all those things before you thrombolyze. If the creatine is elevated.
Yeah, Dr. Suganya has asked about practically difficult in INR platelet things. Platelet is no need to check platelet, no need to check INR for this. Doesn't mean that all patients should undergo this treatment. This means that those patients have risk. Suppose somebody is taking warfarin, somebody is taking heparin, somebody has dengue, or somebody has recent thrombocytopenia. Such scenarios you should do. Otherwise, there is no need to do all those things. Second thing is you can get it done very fast.
CLD. Instead of CLD, you can check.
CLD is another scenario. CLD is very, very important scenario, which we commonly see. And actually, they can get it very, very, very fast. Like when I was doing my PG in my MD days, our during the rounds, sir will come. Dr. Basura sir used to come. Those who are done from MC will know him. He will come and tell, get the CBC. Then we will take the bottle and run, put it in the CBC machine. You will get the report suddenly, maximum 10 or 15 minutes. And the PTNR also in Trivandrum, in government medical college, we used to get it within 15-20 minutes. You can do it. It's not difficult. The machine will deliver report within 20 minutes, usually. At least maximum 30 minutes.
Except for glucose, I think others are all optional. Glucose is mandatory before you thrombolyze.
Which one?
Glucose, blood glucose.
Yeah, hypoglycemia should be corrected and reassess.
Patients with coagulopathy is also, no?
Yeah, non-coagulopathy is a condition where you recheck. Otherwise, if patient is not a non-coagulopathy, there's no need to do all those.
Correct. Patient, especially patient CLD, sometimes they can have coagulopathies also.
Yeah,
it has to be. Yeah.
So that is a major change in coagulation. I mean, major change in the contraindication. So this is a relative contraindication. This comes the most headache part. Pre-existing disability, frailty is never a contraindication now. Bedridden patient also can be lysed right now. DOAC less than 48 hours, you can lyse if you have ability to do the test in time. I don't know in India it is done in any place. Any idea whether anywhere it is done? Like those who are studying in Central Institute or anywhere they are doing the test for DOAC?
In Amrita, they were doing it in between, but because of the high cost and less number of tests, they stopped doing all these things, I think. Right.
Whether they will be getting in time, like within half an hour, 1 hour, you will get?
No, it'll take some time. So one patient with DOAC, I had thrombolyzed after giving idracizumab.
Okay.
Patient was on dabigatran. So that is only safe method before you thrombolyze.
Whether you have the patient blood bleeded or not?
No. Patient had a good outcome. He came with a significant global aphasia. He came within 1 hour of onset. He was just right near to our hospital, and he was on dabigatran. Despite taking the morning dose, he developed this aphasia. And we were fortunate to get idracizumab within 1 hour. We gave 2 vials of 2.5 mg idracizumab. Then we thrombolyzed the patient. The patient improved, I think 80% improvement was there for the speech. Because idracizumab works within 10 to 15 minutes. Immediately, all the effect of dabigatran will be wiped out. Like suddenly, effect will be down to 0.
Great. This is the first time I'm hearing because we.
But nowadays, with idracizumab, it's not available because it was made available by the same company who brought the dabigatran, Pradaxa.
Yeah, previously when we were also studying, they were giving it for free. Any dabigatran and bleed, they will give it for free. But right now, navigator news sources decreased. So they stopped giving that also. So now that scenario is not there. Then
Yeah.
other agents are not that available. That is one major issue. So practically DOACs in Indian scenario, within 48 hours, somebody has taken DOAC, we cannot license. That is a practical scenario in our scenarios. Then ischemic stroke within 3 months, that is again a tricky scenario. What they are telling is you have to look at the core, you have to look at the deficit, and whether there is hemorrhagic transformation. These things should be considered. Somebody like what the practical scenario you will see is patient came to casualty with right side weakness, it improved. Then you take an MRI, you will see an infarct. You admit the patient without a deficit. Then after 6 hours, 7 hours, patient had worsening. So previously, what they are telling was when there is an infarct, better not to. There was no proper guideline. They are telling us when there is a stroke within 3 months, you know lyse. But I always felt like such patients should have been lysed. So I now we have proper guidelines. So such patients can now definitely take it for lysis. And even if within 3 months, if you see new infarct, that is another scenario. Suppose you discharge a patient had right side weakness, left MC there is an infarct, or there is near the internal capsule infarct. Patient come back to you with worsening of weakness. You do an MRI. That same infarct has increased inside. There is no guidelines, but practically that is actually expansion of the existing infarct. That scenario you cannot lyse. So that is again a tricky scenario. What is your Chandu? What is your take on this ischemic stroke within 3 months?
Yeah, we no see it is there is some risk also concerning to it, and so what about lysis? So, you communicate with the bystanders. No, sometimes possibility of bleed is there, possibility of chance of rebleed is there. You have to just communicate and make sure that it has been communicated well, that bleeding chances are all there or not. So that's what so mostly within 3 months, I normally won't go for lysis. That's what I prefer.
Yeah, but the guidelines what they're telling is what then I search in the many articles. What I find out is that the core is small, the deficit is less, and if it is after 1 week, it's actually you go ahead. And if there's a hemorrhagic transformation, core is big, and the image shows the same infarct evolving, better not to lyse.
Yeah.
And I think practically which will help is somebody who come with a minor stroke, should have recovered spontaneously or almost 90%, 95% recovery. Some deficit, they are fine. They view discharge, they came back with stroke. But if there's a new infarct, such scenario now I think you can lyse. Right? What is your take on Partha?
Yeah, most likely, if you have the images of the discharge summary available, many of the time, my personal experience is that they would say that they had a stroke some few months or few weeks back, but we don't know what is the size of the deficit, all those things. That is the tricky scenario. But I think nowadays most of the patients bring some of the like if it is your same center, if you have the image of the previous stroke and you are confident that it's a small one, then you can go ahead with stroke.
Yeah,
If it is in an unknown size and if in your image you see a large stroke, but when you take an image for this stroke, you can see the evidence of the previous stroke also, no? And you see that there is a big lysis or anything is there, then I think it's better to avoid.
I think there we can use a diffusion flare also sometimes.
Yeah.
Like already evolved flare infarct plus unevolved flare infarct, we can consider unevolved flare infarct as a new thing.
Yes,
It's
yes.
something which can use add on to that. And again, hemorrhagic transformation. That is should be something which is very important. That is again SWA and your CT will help. If the old infarct showing hemorrhagic infarct, even now there is no hemorrhagic transformation, better not to lyse. They will bleed.
Regarding that medications also, sometimes they will not bring you the list of medications that they were on. They will just rush to the casualty when the patient has stroke without taking any data with them. So that is another scenario where you don't know what the patient is taking.
Yeah,
Then it's a tricky situation.
actually, we had a patient last week. We actually opened place. Then one bystander came with apixaban. Then we discarded. Otherwise, that would be disaster. So that all happens. Somebody asked about you cannot do qualitative platelet, nothing. You cannot do. You just do platelet uremia and all. No need to do all those things. Like ideally, in CKD on dialysis, you are supposed to do all those things, but that is practically not easy to do. What you can do is a previous investigation you can recheck because if CKD they might have some previous investigation. CKD is one tricky scenario in thrombolysis, right? My experience is almost all patients with just bad bleed is CKD.
Yes.
Or
Yes.
CKD.
Yeah, definitely. CKD is we have very bad experience with the lysis-induced bleed.
Yeah.
Significant microbleeds are there.
Yeah.
Significant microbleeds on MRI.
Moreover, BP will be in a higher refractory BP, or
Exactly.
that is the major.
CKD has all the practical complications. Like they have high BP, they have endothelial dysfunction, they have cortical microbleeds, they may have coagulopathy.
Yeah.
So that CKD expression on dialysis, but that is not a contraindication. But when you are explaining the bystander, you have to explain the risk. That is only practical thing you can do.
EKD patient coming to a neurologist within window period is always worrying.
Yeah, always. And especially during the period of altiplace.
Yeah.
I've seen more bleed in CKD with altiplace than altiplace.
Yes. Yes. Very true. Any thrombolysis in CKD is very bad.
So you can explain the risk and take. Again, the collaterals will be bad in CKD. Everything is bad in CKD because CKD intrinsically has a risk of CABD. Then prior ICH, that is again the most contradictory thing. Prior ICH now considered as a relative contraindication. I'll show the slide because it is very confusing area. Prior ICH, what they are telling is the second thing. If it is because of any other non-cause, like they have an aneurysm rupture, they have something like AVM blood, or they have a amyloid angiopathy, such condition we cannot thrombolyze. But if it is a previous ICH, which is a correctable factor, because like an axillary hypertension, or something like a coagulopathy led to bleed, or a traumatic bleed, such conditions you can still offer lysis with relative contraindication with bleed risk is much higher. Again, when I was reading to some articles, what I find out is that before this guidelines were there, at that time during our preparation during the last sessions, maybe I think was when I was preparing for SS sessions in EAT. I was reading then I find out that they are telling that if there is a cavity with like SW showing cavity like lesions inside the bleed, that or there is a recent bleed within 3 to 6 months, that is also considered as high risk. But guidelines, the present guidelines is not telling anything about that. What they're telling is if there's a non-mechanism, avoid it. If the mechanism is correctable, like a coagulopathy or hypertension, or trauma, you can go ahead with lysis. And Partha, you were telling recently about one patient, right?
Just 2 days back, I had a patient with a prior history of road traffic accident with SDH, which was evacuated with a bar hold. So, because I was confident with the guidelines, with the power of guidelines, I told the bystander that this is a not absolute contraindication, because it's a traumatic intracranial bleed, and that too only a SDH. If it was an SAH or a cortical significant bleed, then maybe I would have not thrombolized. Then I thrombolized the patient. Patient immediately had a very bad hemorrhage.
And you're telling that bleed was not related to STH, that was actually from a brainstem.
In the brainstem stroke, which extended into the ventricles.
So, I mean, what I'm telling is that may not be because of the primary bleed, but the problem is the community. You have to make the bystanders understand.
Exactly.
Sandhu, what is your take on this prior ICH?
The lobar hemorrhage is not
actually.
Lobar hemorrhage is one thing that we have to be a little careful of.
Yeah.
That is what tells us. Always there is a risk factor. No, that's why it's called as a relative contraindication.
Yeah. That is why we have to communicate.
That is why there is the name given as a relative contraindication. So we always have to be a little worried about possibilities of bleed or hemorrhagic transformation. So
practically, what you
can do is,
practically, I think what you can do is if the bleed is because of hypertension coagulopathy, which happened at least 6 months or 1 year before, we can definitely hold bleed and all. You can definitely go ahead.
Correct. Recent bleeds is one.
If it's a recent bleed, again, better you have to discuss the bystander and take a decision on that.
My case, it was like 2-3 years back the bleed happened. It's an old bleed, but still something happened.
I think what they're telling is all these scenarios you have to sit and discuss with the neurosurgeon. That is what they're telling. You have to discuss the neurosurgeon and decide.
Yeah.
See, the main point is that how to convince the bystanders.
Yeah.
So
the bleed happens, particularly.
Yeah, and documentation. These things have to be kept in mind.
Somebody asked about MI and streptococcus. I'll discuss about that later. Then LMWH, you have to do APDT and between then you can lyse. At least even the new guidelines telling you to lyse, but you have to explain the risk and take go away. So you have to explain, you have to counsel the bystanders and about the possibilities to happen. That is why the relative contraindication all are there. A surgery within 10 days, not a contraindication. Again, then surgery within 10 days or a neurosurgery within 14 days or 3 months. All these conditions you have to discuss the concerned department. We had a patient with recent joint replacement. Then we have to discuss the surgeon. Surgeon told if you lyse, it is difficult. The joint may go bad. So we didn't have to proceed. We cannot proceed. So you have to ask the particular department. That is what they are telling. The interdepartmental discussion has to be taken. But how much it is feasible in a remote rural India, I don't know how much it is going to be feasible with the interdepartmental discussion and all. I think such scenarios you cannot lyse such way. That is why it is a relative contraindication. Unruptured AVMs and intracanal dissections, again, not a contraindication right now. Intracanal dissections are also previously also not a contraindication. AVMs and aneurysms are previously a contraindication, but right now, even aneurysms are not considered as contraindication. Previously, what they were telling is aneurysm more than 10 millimeter was considered as a contraindication. So I remember I used to measure the aneurysm size when I was a PG, but right now there is no need to measure because it is not an absolute contraindication. Again, relative. We have to consider a lot of things. I think we have to have a discussion with radiology and neurosurgery, because if it is aneurysm is a narrow neck or high risk of rupture, those things you have to assess and then decide. That is why that is given as relative contraindication. MI within 3 months, pericarditis, cardiac thrombus, all these are relative contraindication, not an absolute contraindication. Active malignancy, pregnancy, and postpartum. Postpartum previously was a within 14 days was uncertain, but now they are giving, you can lyse it, but again have to discuss. Recent GA bleed, GU bleed less than 3 weeks, again you have to discuss with the gastro. Active malignancy, if previously it was like if survival is less than 6 months, no need to lyse. More than 6 months was lysis previously. Now you can again, in such scenarios, I think you have to go ahead with the coagulation profile, everything. Then you have to decide with the oncology or treating physician to decide. The most difficult thing in this is pregnancy for me, because pregnancy coming with this, there are German guidelines, there are Canadian, there are European case reports where they have lyse pregnancy, they're telling it is completely safe. But I don't know how, like if we ask our gynecologists, none of them will going to agree for a thrombolysis in a pregnant lady. What do you think? Chandu?
This is a very tough scenario. No? A patient, pregnant female coming to you with stroke window period, whether to go for lysis or not. So see, in some scenarios, we have to go for. That's what I feel. So we had a patient with a major vessel, pregnant female, and we have gone forward with lysis, and patient improved actually, knowing the window period and all that. And always make sure that the gynecologists are there during that period of time to communicate with the patient's bystanders and convincing them to. See, moreover, the pregnancy time also is it's a hypercoagulable state. So there is a high chance of bleed too. So what I feel is, I didn't have any bad experience with pregnant females going for lysis. So it can have, but I've gone through it.
I have actually never faced a pregnant female coming to with me window period stroke, which came was a large vessel occlusion, just taken thrombectomy. Thrombectomy is easy. Thrombolysis is a difficult scenario. What about Pratha?
Yeah, same scenario. One patient, fortunately it was LVO. So it was during my PG time. So it was straight away gone for the thrombectomy. We could bypass the thrombolysis.
So these are the relative contraindication. Now you just remember that is difficult to remember the relative contraindications and all. For entrance purpose, remember only the contraindications. These 10 things. So that is relative contraindications. So STEMI, again, very recent STEMI, there is chance for cardiac tamponade is very high. So again, they are telling you have to discuss with the cardiology team. So it's not an absolute contraindication right now. Previous lysis also is not absolute contraindication. With streptokinase, previous lysis is not an absolute contraindication now. But you have to discuss with the cardiologist within very few days, like 1 week or 2 weeks. Again, the risk is very high. Better not to lyse it. And again, most of the STEMIs, they may have larger cell. Significant weakness or significant deficit large vessel, they can go ahead with thrombectomy. That is a better option in such scenarios.
Regarding STEMI, most of the patient I have seen are on ticagrelor with aspirin. Very, very high risk of bleed if the patient is on ticagrelor, I feel.
Again, somebody has asked same question. Dual antibody. Dual antibody is never a contraindication for lysis. Absolute contraindication is not there. Even relative it is not put, but the especially when they are on ticagrelor, you have to explain that there is slight chance, but there is no evidence. Nothing is telling that stopping thrombolysis or no added risk according to the guidelines. But the communication has to be there practically. Again, this is what they're telling about the pre-existing ischemic stroke within less than 3 months increases, but timing, size of the stroke should be individualized manner. How much feasible we have to see. Prior ICH increases the risk. You have to tell the definite risk. Again, hypertension coagulopathy can be beneficial. These are on individual basis. So again, those with the AVM bleeds, aneurysm bleeds, better neutralize. Recent non-CNS trauma, again, you have to discuss with the particular surgical experts, and no major CNS surgery, discuss with neurosurgeon. GU and GA bleed, again, you have to take individual decision. Intracranial arterial dissection, safety for IVT is unknown, but still you can take. Add previously also lysis intracranial dissection. It's not an absolute condition previously also, but you have to explain the risk because intracranial vessels lack an extra layer. So they are more thinner and high risk of bleed. So this is the classical indication. I mean, benefits even the previously high risk, the classical, you can go ahead with the lysis, no doubt. Extracranial dissection, reasonably safe. Extraaxial intracranial neoplasms, post-angiography procedure, unruptured aneurysms could be considered. Unruptured aneurysms previously more than 10 millimeter was a contraindication. Now it is not there. Remote history of GAGU bleed, never a contraindication. Moya Moya is again a confusing for me because Moya Moya in older adult can present with bleed. Moya Moya vessels can bleed. So
Moya Moya is one we have to be a little careful of, no? Yeah.
And practically, Moya Moya, many of the times, the stroke which happens in Moya Moya usually recovers with the perfusion, improving the perfusion, and they will have usually minor strokes. Because I had some 4 or 5 Moya Moya cases, all of them as recurrent events, but everything has improved. 3 of them underwent surgery, and all 3 are doing well.
Mainly the collaterals will be very good in these patients because it happens over a slow time, no? Over a bit of long time. So improve the collaterals, make them lie down, reverse Trendelenburg's position. I think sometimes it improve.
Somebody asked about resistance to clopidogrel. Actually, it is very quite common in India. We have done a lot of cases with clopidogrel resistance. That is not a costly test. 2,500 or 3,000, you can do it. But the problem with clopidogrel resistance is there is a dynamic phenomenon. It will the platelet is angry. Like in acute phase, they will be the phenotype is more problematic. But in silent phase, they will respond to treatment also. So we used to, where those who are current stroke on DAPT, first thing is you have to reevaluate to find out the cause. Something you might be missing. Second thing is you change antiplatelet. But what guidelines tell is changing antiplatelet aspirin has no add-on advantage is what guidelines tell. The 2026 guidelines tell. But you can still like what I practically do is I do a clopidogrel resistance and I'll change to Blinda and I'll reevaluate for etiology. Probably same will be both of you will be doing.
Same.
True. Yeah.
So basically, one thing I want to tell is this thing. It's the 2019 guidelines, acute MA. So acute MA, when they come with stroke, lysis with PCA for heart. That is a guidelines. That is same in even now also. Recent MA is a confusion which is there in the new guidelines. What I practically tell is, in 2019 guidelines, you can take as a marker. Those scenarios which are like STEMI of left myocardium, 2B. This should be very, very problematic because ventricular rupture, cardiac trauma is high risk. So you can explain with the risk and take them because it is not a contraindication, but you can explain them. So STEMI with a left myocardium, but NSTEMI or STEMI of right or inferior wall is not a contraindication. So that is relatively safer. That is how you can debate. But many times you don't know what is whether it is STEMI or NSTEMI because they will come with history of MA. They are treated in the same hospital disease. Otherwise, it is difficult. So you can even use the 2019 as a step for managing patients. Acute pericarditis, LV thrombus, again, it is maybe reasonable because LV thrombus sometimes they can dislodge new thrombus into the large vessel. So such patients, if they worsen post lysis rather than bleed, you should also think of a thrombus going into a large vessel. So you should do a angiogram repeat if CTS doesn't show a bleed after worsening with lysis, and you may have to do a thrombectomy. And this is old guidelines, but they can use this for as a step plate. So that is what I felt. What do you practically do in your scenario, Chandu? Like a patient with recent MA comes to you with the stroke, what you are doing? Like if you know that they have NSTEMI or STEMI.
See, I go for lysis. So within 3 months, No, the other thing is that what you told about STMI, left myocardium, there is some risk is there, but patient with recent MI, I most probably go for lysis.
Yeah. And Chandu, and Partha?
Same thing I told previously. If the patient is on Brilinda, I rather not go for thrombolysis. If there is on clopidogrel, DAPT with aspirin, might be considered.
Yeah, I also think that I used to lyse it. Like if it is right myocardium, STEMI or NSTEMI. NSTEMIs I used to directly straight away go with lysis. STEMI also I had lysed a lot of cases in STEMI and right myocardium. Because we had a good cardiology department here. So many of the patients, this is a vulnerable phase when they have MA.
And we have a good evidence that even with patients with antiplatelets, we can go forward with lysis.
Yeah.
So,
but you have to explain there is a risk.
yeah,
Definitely.
definitely.
There's an add-on risk.
I had a very bad experience with ticagrelor. That is,
Ticagrelor, correct.
yeah.
Be extra counted.
So I try to avoid in patient with ticagrelor.
Yeah.
There are not much studies on ticagrelor with lysis.
Yeah, this actually stroke and their stroke areas every day something new will be coming up. Something.
Aspirin clopidogrel I used to lyse, especially if it is an STEMI and all those things.
And Prithvi has asked a question that patient with RTA, hemothorax, ICD, do stroke syndrome. You should not lyse because this is where you have a non-compressible bleeding site. That is a contraindication.
Yes.
Active bleed, which is non-compressible, is a contraindication. This compressible site, like a fingertip or somewhere periphery, it is you can lyse. Active bleed, non-compressible, never lyse.
I had a same patient, RTA, ICD with stroke. And on CT angio, it was found to be having a dissection of the brachiocephalic trunk.
See, basically, such scenarios, you just have to sit and think. Not just think like you are going to lyse the lyse. If you are not lysing, it is going to be a problem. Nothing like that. You have to understand that if it is reasonable, you can go with the procedure. You have to just sit, decide with yourself. If you want, you can ask a surgeon. Communication is very important. Ask a surgeon and discuss with yourself that if you lyse, whether this will be harmful to the patient. What is your aim is do no harm. That should be the basic thing. And if you document well, nothing is going to happen. You document well, medical legality will not be there because this is what is practically going to happen. This is a dynamic scenario. So this is a new contraindication: CT with hemorrhage, CT showing extensive hypertension, intraxial neoplasms, and moderate to severe TBA. You can even include, not actually this coagulopathy and thrombosis in that spectrum. You should also include non-compressible bleeding site. Anywhere there is a non-compressible bleeding, active bleeding, that should be a contraindication. If it is compressible, well and fine. Something like bleeding from the catheter, menstrual bleed, these are not a contraindication. But again, menstrual bleed, if they have active large amount of bleed, you have to take an opinion from gynecologist. I have faced some scenario like that, menstrual bleed with both cases, menstrual bleed with CVT, menstrual bleed with stroke. Any experience in that?
CVT, yes. A lot of patients, but you don't have considered thrombolysis in those scenarios.
So
there may be some worsening of the menstrual bleed.
Yeah, actually, recently we had one case, and our neurointerventionist came with a wonderful idea because you have to anticoagulate. What we did was an embolization of uterine artery.
Yeah.
So that is easy to do rather than open surgery. So after that, bleeding completely settled down.
Yes. I have one scenario. Patient had a stroke and he fell down, had a fracture of the femur. So thrombolysis or not? There is no active bleeding now, but he has a fracture.
You cannot thrombolize. Femoral femur fracture is non-compressible site, definitely will bleed. Second thing is such scenario, whether it is stroke first or fracture first is another thing because they will slip and fall. Fat embolus usually happen a little bit delayed, but it can occur still.
So I searched in literature. There's few scenarios are there. If the shaft of the femur is fractured, more likely for bleeding. If it is just the neck of femur, then less chance of bleed.
Again, in such scenario, you have to ask the question from the orthopedicians.
Yeah.
Interdepartmental discussion is where this guidelines has given more importance. So basically, these things given the bold has to be cautious. Previous guidelines negative, now it is not negative. So basically, remember the contraindication at least 3 things in image, 3 things from surgery, and 4 things from systemic things. So that is what about the contraindication. Take home from the thrombolysis is basically any disabling stroke, if eligible, lies down. Tenantable better evidence is there. New thrombolytics are discussed. Wake up or lysis up to 4.5 to 9 hours. Always think From wake up after 4.5 hours, it requires CT perfusion. Extended lysis of LVO up to 24 hours if EVT is not possible, again based on salvaging penumbra. Pediatric stroke, EVT and IVT guidelines is right now, and pediatric stroke number we have discussed previously, it is only alteplase from 28 days above. And changes in the contraindication is also there. This is one point I want to tell about lysis. One is tenalteplase. In those, we are discussing about those elevated bleeding risk. Such scenarios, whether you should use a subtherapeutic dose, like a lesser dose. There are some discussions behind that. I think that might be a feasible option in the future, especially in Indian scenarios. There, what we can do is we can go with 0.2 mg per kg rather than 0.25 mg practically to be in the safer side. So that is also feasible. I had seen some patient subtherapeutic lysis also improving very well. And one more scenario is when you have a large vessel, you give a lysis, the thrombus may dislodge into distal vessel. That is very, very common with tenalteplase more than alteplase because tenalteplase is more potent. So post lysis clot migration, that is very, very common. I had many cases with clot migration, went to worsen, then we did thrombectomy. Those things can happen. From vertebral going to basilar, causing basilar thrombosis, those things I had seen. So, what is your experience with subtherapeutic? What is your opinion on subtherapeutic dose, Dr. Chandu?
See, if there is no patient having a higher NHS score and less aspect, and that means your core size is a little more. So you have a large core size of infarcted area. I feel better go for a subtherapeutic dose. Otherwise, some possibilities of bleeding is too high. And the two major vessel occlusions, especially LVO, M1 occlusion, proximal M1 tandem occlusions. So there is always a risk. And it's always, I feel it a little safer to give a subtherapeutic dose. So doing harm than say, being on the safer side. I usually follow that.
Yeah, that is where like 0.2 milligram, 0.25 milligram. Like whatever.
I don't think any harm has been. No, I think it's more beneficial.
More beneficial.
More beneficial.
Medical legal stand of thing, overdose is more problem. Underdose is
more problem. And these are all Western guidelines. So our Indian scenarios, our ethnicities, and
I think you have to document that. So I think.
Yeah.
And
we normally don't communicate to patients, bystanders, that we are going for a subtherapeutic dose. That is another point we have to be careful enough. So they might be in a dilemma that seems that we have not given the optimal dose. The patient has worsened. So these things are
basically our aim should be to do no harm. That's all.
Yeah, no harm to the patient. That's it. And so always a double-edged. No, it's always a double-edged sword.
Yeah, always.
Always.
And Partha, what is your opinion on this one, like clot lysis and by migration?
So there were 2 or 3 cases recently. Same thing had happened. Those patients, when they post thrombolysis, when they were taken up for DSA, the clot had migrated, so they couldn't take up the thrombus. Previously, it was in the proximal MCA, and once it is lysed, it went to the distal branches, so we couldn't retrieve the thrombus.
It happens. And one more thing is like for students who are waiting there or the practicing persons, like classical guidance is 0.25. You can use even 0.2 according to Indian guidelines. You can even stand in medical issues telling that is 0.2 is also reliable dose. And basically, like Chandru was telling, do no harm. That is a basic thing you have to think. You have to use a lot of common sense, a lot of things when you're managing stroke. It's not as simple like a guideline. So that finishes the lysis. We will go to the EVT. We have to finish EVT within 20 minutes, I think, because we almost touching 2 hours. So EVT, the whole guidelines is very, very easy. Endovascular therapy, it is very easy. Like 6 was the cutoff. Aspects more than or equal to 6, NHS more than or equal to 6, within 6 hours, best evidence. That was there. Then again, there was no proper guidelines on posterior circulation. And the medium vessel occlusion like M2, M3, ACA, vertebral artery, basilar artery, PCA, all those can be done in 2B based on all guidelines. And up to 24-hour lysis was previously also there in the old guidelines. So what is new in the new guidelines is window of anterior circulation of 24 hours was previously there, but evidence has improved. Second thing is previously the aspect score has to be above 6 or above. Now with the level 1 evidence, you can lyse up to an aspects of 3. I mean, you can thrombectomy up on aspects of 3 with a level 1 evidence. And lesser evidence, you can do even thrombectomy for an aspects of 0. Then I was reading to that what they're telling that previously core was considered as those infarcted tissue. But what they're telling is those with a CT or MRI showing the core may not be an infarcted tissue. It is a tissue at risk also. So there may be some, it is not completely damaged tissue. That is a concept of low aspect thrombolysis, thrombectomy. That is why they are going to trying to do with the low aspect thrombolysis in multiple studies also. Timeless, all those studies are done on low aspect as well as later window because they're thinking that what are you seeing the CT or MRI may not be completely irreversible tissue. There will be some reversible tissue in that. The concept of core has changed. Then the basal artery, previously there was no guidelines. Now basal artery up to 24 hours can be taken up with good evidence. And median vessel occlusion, previously all median vessels there was some evidence to do, but right now it has changed. Tandem occlusion, suppose somebody has a occlusion ICA and somebody has occlusion MCA. Those were previously only thrombectomy was suggested, but now stenting is better evidence. And most importantly, pediatric thrombectomy evidence. So this is the basic new things in the EVT guidelines. So this is a anterior circulation guideline. Somebody who present within less than 6 hours with an MRS of 0 to 1, MRS of 0 to 1, that is previous disability is very minimal. Then with up to aspects 3 within 6 hours, NHS more than or equal to 6, you can take with 1A. Almost same as 2019. Only difference is previously the aspect 6 above was a must. Now even with the aspect of 3, even 1A you can take. The best evidence is there. Within 6 hours, aspects less than 3, also you can take for thrombectomy. Preferably the age is less than 80. So lower the aspect, the higher age group has higher risk. So lower aspect thrombectomy is there, less than 3 is there, but up to 0 is there, but the age should be less than 80. More than 80 with significant mass effect, you should not do. That is a takeaway point from that. And 6 to 24 hours, aspect 6 to 10, again, you can do within 24 hours at the level of 1A, preferably you had shown salivary tissues there based on perfusion or DON or diffuse criteria. DON is based on MRI and clinical, while diffuse is based on diffusion perfusion criteria. Then lower aspects 3 to 5, and you remember this thing: a patient comes with a window of 6 hours. Up to 3 aspects you can take, 10 to 3 aspect you can take with the best index. Less than 3 within 6 hours, you can take, preferably age is less than 80. If it is window is 6 to 24 hours, the aspects is best evidence is 6, not 3. The aspects 3, the best evidence is less than 6 hours. This is for entrance. Then, if 6 to 24 hours, aspects less than 6, the evidence is much lesser, but age should be less than 80. I think it is a bit confusing, but just at least remember lower aspects still now can be taken. So basically, this is a concept. Less than 6 hours, aspects 3 hours, 3 or above, best evidence. Less than 3 can be taken if age is less than 80. If window is 6 to 24 hours and MRS 0 to 1, aspects more than 6, any age without mass effect level 1 evidence. Aspects less than 6, if age is less than 80, can be taken. So basically, lower the aspect, age should be much important because the studies has done only for patients up to age of 80. So basically, Chandu and Partha, what is your opinion on lower aspects thrombectomy?
So the main change in endovascular therapy, what happened now is they are incorporated small core size into the endovascular therapy, which was not there previously. So previously it is like aspects of more than 6, NHS of more than 6, all 6 comes into play. And time period within 6 is a criteria for taking for endovascular therapy. Now they have taken 3 to 5, aspect of 3 to 5, or even they have taken 0 to 2 with age into consideration. If more than 80 years of age, 0 to aspects has been taken, and even now they follow that mass effect. They're taking the imaging criteria too. If the aspect is 0 to 2, if there is no mass effect in the imaging, they can be taken for EVT therapy. So that's what they now their core size, the smaller the core size or larger the core size, they are taking into the consideration for this latest criteria. That's all. The core has come into play. The time period is like 0 to 6 or 6 to 24 hours. And more the NHS score and pre-MRS, it can be 1 to 2, it can be moderate also. Like some criteria tells you that guidelines of class 2 guidelines tells you that MRS can be taken to 2 or even 3 to 4 with aged consideration. If it is greater than age, there is a risk, but less than 80 years can be taken without mass effect in MRI.
Partha, what is your opinion on low aspects?
Low aspect, I would ideally, as per the guidelines, we just have to look at the MRA, and if there is significant mismatch as per the Dawn criteria, we can go ahead. But I think it is better to go for additional imaging techniques in such scenarios, just to prove that you have definite salvageable tissue there before going in with the thrombectomy, because it's an expensive procedure. 2-3 lakhs will be spent on that, and on top of that, if there is a significant bleed and everything, it will be difficult. So if you have an MRI diffusion flare mismatch, maybe you can go for a CT perfusion if you have the facility, or if you have a mark perfusion like ASL or something, then I think it is better.
So I also think the same. Like lower aspects, you have to be cautious. Aspects up to 3 is well and fine. Below 3, you can take, but you have to be cautious. Again, age. Again, the problem with age is the brain age or the collateral age is much different from what is a practical age. That also has to be collateral has to be considered. There are some of the studies, I think Escape, they had included the collateral also into the studies. So I think that also has to be included when we are discussing, when you are planning, like those have lesser collaterals, higher risk of bleed and higher risk of progression. So better collaterals, they will have better outcome. That also has to be like interventionists, they know it. They used to do based on the DSI imaging, they do based on that collateral also. So that those things actually they are not mentioning, but that is definitely has to be taken into consideration. So basically, the students, this is a basic summary. Less than 6 hours. Previously, it was 6 was the aspect cutoff. Now up to 3 was the best evidence. Less than 3 can be taken 80 is age. And 6 to 24 hours, again based on Dawn and diffuse criteria, the same criteria which is using previously, same can be used. Where Dawn is based on MRI and clinical. That is a best and easy thing to use even the practical scenarios. And aspects less than 6, again age has to be importance in 6 to 24 hours. So 6 to 24 hours, 6 is the cutoff. Less than 6, it is 3 is the best evidence. There are some caveats they are giving, like for those with 3 to 5, 80 years, renal failure, refractory hypertension, comorbid psychiatric illness, which can confound the neurological assessment, life expectancy less than 3 months. So these also should have been considered when you're taking a lower aspects practically. One more thing is a lower aspects, particularly in outside 6 hours, if you have CT hypodensity of more than 26 ml, more than 26 Hounsfield, that better not to take. So how to make this Hounsfield practically is contralateral thalamic gray matter. Previously we discussed contralateral white matter. More than dark than that is a contraindication for a, we can call it as extensive hypodensity. So here it is more than 26 ml and less than 26 Hounsfield or contralateral thalamic gray matter equivalency. So basically a lower aspect, you always have to take into consideration of the age, coexisting comorbidities like renal, refractory hypertension, and see the intensity of CT hypodensity if you're taking CT. These are 3 things you can access, and again collaterals you can add on. So this was previously we were discussing about MRS up to 0 to 1. There is no significant disability, but 2 to 6 were previously not included. But now MRS 2 can be taken at level 2A and MRS 3 to 4 can be taken at level 2B. But for a lower MRS, suppose the patient is bedded on previous stroke, then you have no extended window. You can take only up to less than 6 hours. You can take with aspects more than 6, NHS more than 6, classical previous guideline criteria. So poor MRS LVO, you can take with a lesser evidence, but it has to be within 6 hours. Aspects has to be more than 6, NHS has to be more than 6. Outside 6 hours, there is even now there is no criteria for poor MRS. So new, like I had seen many videos that telling even poor MRS they can take for lysis, thrombectomy. But there is a caveat, it should be within 6 hours. And aspect should be more than 6. That is very stringent for a poor MRS. You cannot take an extended window in poor MRS according to later criteria because they have more chances of lesser, better outcome. Like Partha was saying, it is a more costly procedure. The outcome has to be counted. So basically, this is the thing. LVO up to 24 hours can be taken. Aspects up to 3 is a best evidence. Up to 3 aspects, it's best evidence. But if the window is slightly lesser, like more than 6 to 24 hours, the aspect is against less than 6 as lesser outcome. And when you do a lesser aspect or when you're doing outside 6 hours, the 80 years has to be a consideration you have to consider. And then those with the poor MRS can be taken. Poor MRS can only be taken if it is within less than 6 hours, aspect 6 or above, NHS 6 or above. That was about and a key score is that 2B, 2C, and 3 is what again for entrance, not for others. These are what are expected better outcomes in a thrombectomy. So this is another difference is a medium vessel occlusion. Previously M2, M3 or ACA can be taken. Now it is considered as only for dominant M2 division can be taken for thrombectomy. So dominant is not your left side or right side. It is suppose even if right side can be dominant, if the M2 division, that is the horizontal branch followed by the those going into the upward, that is supplying more than 50% of the entire MCA. I had told you that MCA supplies 3 areas mainly. So more than 50% of that 3 areas is supplied by M2. Even if it is on right side, it should be taken as dominant. So dominant M2 division, there is a good evidence to do. Again, MRS score of 0 to 1, NHS more than 6. The classical 666 rule applies there. Within 6 hours, aspects more than 6. So the new things, poor MRS and the median vessel occlusion, the classical 666 criteria has to be met, and MRS should be 0 to 1 for MBO. So non-dominant median vessel occlusion, better not to chase. Non-dominant M2, ACA, PCA, distal MCA, all those things, there is no need of thrombectomy is what they clearly tell, no benefit. So you might like previous guidelines, they're willing to take it. So previously we were trying to aspirate it, ending up at complications. Those things were there. Now it is very clear. So I think both of you, like, what do you feel like practically this will be much more helpful, no?
I had a very bad experience with more this kind of PCA as well as ACA, all those things. I think better to avoid. The guidelines are now very clear.
Yeah, the non-dominant medium vessels or distal vessels has to be avoided. So
basically,
yeah,
continue.
Yeah, dominant M2 proximal can be tried. It all depends on the skills of the interventionist, the radio interventionist to do it. But there's a strong evidence of strong guidelines now tells you that dominant M2 can be taken. Medium vessels can be taken. So
yeah,
that is the change which is been with the difference between the previous 2019 guidelines and 2026 guidelines now.
So basically for students, you should understand that medium vessel means after M1. So, or ACA, PCA, there's now confusion is gone. Like somebody who has a PCA occlusion, whether you should refer for thrombectomy, no. Right now, those with the PCA, ACA, distal M1, distal M2, or a non-dominant M2, no need of doing MBO. How to differentiate dominant and non-dominant? You have to do a DSA, or you should do a CT angio decide. So that decision might have been taken by an interventionist. That is where only confusion happens when there's an M2. But distal to M2 or ACA, PCA, there is no need to worry. You cannot thrombectomy. That is very clear from that. So posterior circulation is where the major change happened. Up to 24 hours, you can take. Again, I have a confusion because they are mentioning NIHs more than 10. NIH score has less validity in posterior circulation. That is something which it strikes me. What do you feel?
Yes, definitely.
So
in the posterior circulation, they are a little NIH score will be definitely higher. The presentation, clinical presentation with posterior circulation. So
sometimes they can fool you also, like they present just with confusion, like classical basis.
Yeah, correct.
Not any weakness. So NHS may not be that much high, but you will end up at losing the patient. So like previously, what we have done, like plenty of basal artery. Like our interventionist, Dr. Deshiram sir, he has done a lot of basal artery dialysis with us, and most of the cases, what he chose was based on image, whether a brainstem is patent and whether flare changes in brainstem is developed. Actually, recently we had done one case with some changes in the flare also in the pons. She was quadriplegic, basilar artery. There are changes in the flare, significant changes in the flare, but she came last week for review. She was walking. So circulation is still a mystery. You have to wait and watch. But anyway, we have a guidelines. We can take post circulation up to 24 hours. But what for entrance purpose, NIHs should be more than 10 for the best evidence. 6 to 9 can be taken. NIHs less than 6, there is no indication to take based on this. Again, post circulation aspects is there. Again, what we were discussing previously. PC aspect has problem CT. PC aspect, CT may misread. So we don't know whether. So we have to go with the MRI. It's a better tool in post circulation basically. So basically, post circulation, NIHs more than or equal to 10, aspects of post circulation more than or equal to 6, MRS 0 to 1 within 24 hours the best evidence. But Up to 6 to 9, you can take. Less than 6, there is no need to take for thrombectomy. You have to just wait. If it worsen, you can take further. So this is tandem occlusion. Tandem occlusion, you have an IC and proximal MCA. So previously, you can do a, previously what they're telling is you do a thrombectomy of the MCA and keep the IC and stent it later. But right now, you can do both together. We had seen a lot of cases being done with ICSing right now. Yesterday, we had done a patient with stenting and ICA with thrombectomy of MCA. So that is quite common nowadays. That has a better evidence now, tandem occlusion. So the change in tandem occlusion is basically stenting has more evidence. The problem with stenting is, again, with stenting, you have to give dual antiplatelets. So the risk of bleed above may be high, but you have to compromise. So there is no choice, because once a stent thrombus occurs, it is gone. You cannot do anything. So you have to prevent stent thrombus once you're done stenting. And sometimes they'll give inside the stent some ticagrelor also. So that is again a difficult scenario. So this is the last one, pediatric stroke in EVT. Very difficult one. So what is your opinion on pediatric stroke in EVT? Because the catheters, the size of the vessels.
I have not seen a pediatric EVT. I think
India, I
they-
don't know whether they're doing or not.
The new introduction.
they have done few. I've seen the Instagram pictures of AIMS Jodhpur. I think they have very good interventionist. They post on the Instagram the pediatric thrombectomy.
So basically, pediatric thrombectomy, what they're telling, those who are exposed to pediatrics, but now it is difficult in Indian scenario, but slowly we will start doing, hopefully. Thing is, problem with pediatric thrombectomy is, again, the vessel size may be less, the mobility of catheter, everything has to be decided by the interventionist, which I am not exposed much, because I don't know much about intervention lab other than seeing our interventionists doing it. So basically, this best evidence is 2A, not even 1, for more than 6 or above, less than 6 hours of LVO. So it is again 6, classical 6 foot is the best. More than 6 years, 6 to 24 hours, salvageable penumbra, again, dawn and diffuse. You can do again with 2A. But 28 days to 6 years, the evidence is much less. You require much trained interventionist. And acute neurologic syndrome, including first seizure, if with LDO, you can do it up to 20. So basically, pediatric EVT can do up to 28 days. But best evidence is above 6 years. So EVT take home is LVO up to 24 hours can be taken. Aspect which we have discussed. Post-circulation better evidence. Tandem occlusion stenting has better evidence. Pediatric EVT. So this is one slide I want to show. This is two software which has been used for perfusion analysis. You can see there is a lot of difference in the both softwares. Volume variation, all those, because basically these softwares use on certain algorithms. The algorithm differ from different software. That is one problem with perfusion. So always you have a clinical judgment along with perfusion when you're doing perfusion, and always MR diffusion flare mismatch or diffusion clinical mismatch. The Dawn criteria is much more better than perfusion is what that article was trying to convey. So with that, we'll wind up. We have discussed about the imaging of stroke, general management, thrombolysis, external window lysis, contraindication of lysis, EVT, and pediatric stroke management. I'll just summarize what all things we have discussed. Imaging in stroke, basically it is MRI or CT, whichever you can do within 24-25 minutes is a best. Within that time, that has to be done. Suspected LVO, always go with angiographic imaging. But if you have delay in doing angiography, lysis, then do angiography. Pediatric MRI, pediatric is where MRI is a must. Another thing is a wake-up stroke. These are two scenarios where MRI is must. So pediatric, MRI is preferred if you can do within 25 minutes. If you cannot do within 25 minutes, you go with CT. Again, a lot of mimics are there. Wake-up stroke, MRI diffusion flare mismatch within 4.5 hours. More than 4.5 hours up to 9 hours, go with perfusion image from wake-up. So patient wake-up, within 4.5 hours from wake-up, you go with MRI diffusion. Post-circulation aspect has been introduced. The major thing is in imaging in thrombolysis. Imaging in EVT, again, almost same. CT angio within 6 hours, more than 6 hours MRI or perfusion images required. The new change is direct triage to angiographic suite. For a raise score more than 4 with LVO, you can directly shift to angiographic suite, take a plain CT, lies there, take for DSA. That can be considered as a major thing. That is the only change which has happened in the imaging in EVT. Then general measures, oxygen supplementation can be given with normal saturation for LVO patients who are going to take for EVT. Second is post-lysis, a BP less than 140 is not beneficial. So 180 to 140 is a better range of BP. That is a new thing. Then again, insulin and all those things I'm not going to go. These are major two things which has been there in the general measures. Then lysis, irrespective of NIHs or aspect, disabling stroke if eligible for lysis within 4.5 can lysis. Definition of minor stroke is much more clearer now. with there are certain things which are discussed. In the main part we discussed in the first video, that can be taken for lysis. And always assess soloing and always assess the gait when you're dealing with a minor stroke. So basic activities are affected, then you should lyse it even if NIH score is less. Minor stroke, the cutoff is NIH is 5. Tenalty plus evidence is much improved. Dose is regularized. Now it is 0.25 milligram per kg. DGC approval or the Indian Drug Authority approval is 0.2. And other thrombolytics, reticlis and prouronkinase is there. Periodic thrombolysis is there, but 28 to 18 years, again, it is alteplase, not tenalteplase. Extended window, if it is wake up less than 4.5 hours, go with MRI. Diffusion flare mismatch, lyse it. 4.5 to 9 hours from the wake up, you go with CT perfusion, MR perfusion. Then if salvageable penumbra, lyse it. More than 9 hours up to 24 hours. That is 4.5 to 9 hours, 24 hours. More than 9 hours to 24 hours without LVO, medical management. With LVO, whether it is wake up or non-wake up, if an LVO presenting after 4.5 hours, if they are not taking for EVT, you can offer lysis, but there is a risk of bleed. Only you have to prove that. Only thing you have to prove that there is a salvageable penumbra. Again, it requires high-end imaging, which is sometimes it is difficult. So specific scenario we have discussed, CRVO, IVT is uncertain, is a major takeaway. Then 10 major contraindications are these: CT with hemorrhage, CT showing extensive hypodensity, interaction neoplasm, all those things you have to remember. Then EVT in 2026 new update is basically window of anticirculation 24 hours, previously also there, but evidence is much better. Lower aspects, lower MRS can be taken, up to 0 can be taken. Basilar artery, previously there is no guidelines, but now basilar artery up to 24 hours, NIHs more than or equal to 10, best evidence to do. Medium vessel occlusion is a major change where dominant M2 can be taken, distal M2 or non-dominant ACA, vertebral artery or other medium vessels which are not considered as for in the thrombectomy right now. Tandem occlusions, better evidence for stenting now. Pediatric thrombectomy evidence is there, more than 6 years, the best evidence. 28 to 6 years also evidence is there, but evidence is much lesser than other population. Again, it has to be an experienced pediatrician, pediatric interventionist. So this was poor MRS pediatric lysis. So take home basically lysis in disabling stroke can be lysed. New thrombolytic discussed. Wake up lysis up to 4.59 hours is there only if there is a perfusion image. External lysis of LVO up to 24 hours. If EVT is not possible, again you may have to prove the penumbra by using a perfusion or other modality. Pediatric stroke EVT and IVT guidelines are there. So this was about the thrombolysis and thrombectomy discussion. This is an extensive session, I feel, like because this is a huge guideline. So Partha and Chandu, thank you for being there.
Thank you.
Thank you.
Lot of learning points.
One question is, what about decision of IVT or EVT in patient with initial NIHs less than 6? But stroke inhibition, there is nothing known as stroke inhibition right now. Those theories are not there right now. So basically, you see the NIHs and tell that whether it is minor or major. Less than 5 is minor. If less than 5, you think whether it is disabling or non-disabling. Disabling, you lyse. Non-disabling, you don't lyse. For large vessel also, less than non-disabling, you can wait. If good collaterals, you can wait. If non-disabling, not a good collateral, then again, you may have sometimes. So that is again depends upon the interventions. So what do you feel about that question, like non-disabling large vessel occlusion?
Those hemodynamics will come to play. In those cases, I think it is better to keep the BP on a higher level. If it is a non-disabling, do not thrombolyze. Watch for the hemodynamics. Do not try to control the BP. If the BP is going above 220 only, I think you should give some medicines. Most likely there will be a large vessel occlusion somewhere, and you try to keep the hemodynamic stable. If patients then worsen, I think directly you can take it for thrombolysis or thrombectomy, depending upon the scenario.
Just maintain the BP. That auto regulation has to be maintained.
Yeah, and practically, I've seen many patients. When such patients sit up in sitting position, they will worsen. So make them at least 30-degree inclination with good fluid, maintain BP, and always check for the collaterals in angiogram. Good collaterals, they will be stable. Bad collaterals, they will worsen.
Correct.
So chronic atheroma is difficult to remove through thrombectomy. How can we predict it? We have something known as vessel wall imaging. You can predict the type of the atherosclerotic changes, whether it is whether there is a bleed, whether there is a lipid lipid has been there, or whether there's an ulceration. These things can be found out, but again, in acute setting, it's difficult to manage. Basically, if it is calcified, difficult for thrombectomy, but you still try for it. Sometimes it is we cannot able to cannulate also. There are some scenarios many of the interventions I faced. They will try very difficult to cannulate. That happens. Chronic atheroma, there is no need to remove it. If it is a calcified chronic thing, if it is a stenosis, you can stent it. Or if significant calcification unable to do, you do a endarterectomy. True. That is very true. Difficult to treat. What
It
if
was very simple 20 years back. Now it is getting
not
complicated.
20, like when we were doing MD, it was very simple. In 2014, 15, it was very simple. Now it has become very difficult and requires a lot of cognition to put into that.
Lot of guidelines, you know.
Yeah.
And all these things will come at 2 a.m., 3 a.m. the night when our brain is not working properly.
Yeah. So that's all. Thank you all.